Wakenya wote tunawasihi, tega sikio, tumejaliwa nchi tukufu, inatupasa sote tuilinde. Sisi sote ni wamoja, tujivunie Ukenya wetu. Kenya ni baba tena mama yetu. Michezo yaunganisha kwa pamoja. Tucheza kandanda na nyimbo tamu, tucheza kandanda na nyimbo tamu. Tuungane wazalendo.
Thank you so much. Let's appreciate our KEMSA choir as they leave the stage under the leadership of Mwalimu Vincent. Let's give them a round of applause, ladies. Tuwapigie makofi jameni, tuache uchoyo. Wametutumbuiza kwa nyimbo nzuri na nasema asante. Mwenyezi Mungu awabariki. Mwenyezi Mungu awabariki. Tunasema shukran. So thank you so much. Just to inform my good friends that our principal guest is already with us. Mgeni wetu rasmi mama taifa tayari yuko nasi. Kwa hivyo atakuwa anajiunga nasi wakati wote atakapoingia hapa na nitawaelekeza kadri atakavyokuwa akija. Wanaoingia uwanjani hivi sasa ni kwaya yetu ya SHA wakiwa chini ya mwalimu mzoefu wa muziki Bwana Nick Emodia. Wanataka kutuletea burudani. SHA kwaya, tafadhali mtupe wimbo.
Mashariki, tuwezeshe kuishi kwa Mikuzo yetu idumu, jumuiya yetu. Kwetu ni rafiki ya mwanadamu, afya bora ndiyo maisha mema. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora.
Tupate lishe bora,
Tuwe na afya nzuri,
tutunze mazingira,
tudumishe usafi.
tupate lishe bora,
Tuwe na afya nzuri,
tutunze mazingira,
tudumishe usafi. Afya bora kwetu ni rafiki ya mwanadamu, afya bora ndiyo maisha mema. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora.
na ambulance hizo
Juhudi za serikali
kujali masilahi,
twashuhudia,
tusije kapoteza
maafisa wa afya
kwenye nchi za mbali.
nchi za kifahari. Afya bora kwetu ni rafiki ya mwanadamu, afya bora ndiyo maisha mema. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora.
Madawa ndiyo hayo,
Kenya tunayapata,
mashini za kupima,
magonjwa kila aina,
hatutakimbilia
nchi zile za mbali,
kwenye nchi za mbali.
nchi za kifahari. Afya bora kwetu ni rafiki ya mwanadamu, afya bora ndiyo maisha mema. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora.
Twatenga pesa nyingi
Kwa wizara ya afya
kwenye bajeti zetu,
zote za kila mwaka,
tusije kapoteza
maafisa wa afya
kwenye nchi za mbali.
nchi za kifahari. Afya bora kwetu ni rafiki ya mwanadamu, afya bora ndiyo maisha mema. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Palipo chuki na ugomvi nilete upendo,
ili Wakenya wote waishi kwa upendo kwa kweli.
Palipo chuki na ugomvi nilete amani,
ili Wakenya wote waishi kwa amani tele.
Popote palipo na mtengano nilete umoja,
ili Wakenya wote waishi kwa umoja kwa kweli.
Popote palipo na mzozo nilete amani,
ili Wakenya wote waishi kwa amani tele.
Yelele yelele,
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Sound check on 2. Mwalimu Emodia, huo wimbo unazungumzia masuala ya amani, na zote tunaambia Mungu nifanye chombo cha amani yako. Ni sala iliyofanywa na Mtakatifu Fransisi wa Asisi. Nitaomba tusimame sote. Tusimame kwa sababu bado kuna baridi, na mwalimu ukitupa huo wimbo nitaomba kila mmoja wetu, let us dance to the song and clap. God, make me an instrument of peace. Can you repeat with me? God, go with me. God, make me an instrument of peace. Talk to yourself. Talk to yourself. God, make me an instrument of peace. Mwalimu, give us the peace and let us clap. Hata kama hujui wimbo, unasema tu Mungu nifanye chombo cha amani. That is a clarion call for us, because our country, we only have one Kenya. And if we destroy it, where do we go? Mungu nifanye chombo cha amani. Na tuimbe sasa kwa sauti kwaya, ndio tuimbe sote.
Mungu nifanye niwe chombo.
Let us clap all together.
Nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo.
I cannot see people dancing. Dance like the choir. Go to the right, go to the left, to the right, to the left, to the right. Angalia, nione, ona. Twende. CH, please, asante sana. Munashika haraka.
Palipo chuki na ugomvi nilete upendo.
Kanyaga. Mungu nifanye chombo cha amani.
Na ugomvi nilete amani.
Ili Wakenya wote
Wapi daktari?
Popote palipo na utengano nilete umoja.
ili Wakenya wote waishi kwa umoja kwa kweli.
Popote palipo na mzozo nilete amani.
Ili Wakenya wote waishi kwa amani tele.
Yelele.
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye.
Kama unaamini wewe ni balozi wa amani, inua mkono wa kulia. Twende. Let's go. Balozi wa amani. I'm an ambassador for peace.
Nilete faraja.
Mimi ni balozi wa amani. Let us say Yes, Lord. I'm an ambassador for peace. Are you an ambassador for peace like Mike Getone? Ati maswala ya kisiasa yasitutenganishe. Sote ni taifa moja. Haya, kanyaga. Kanyaga na utembeze mabega. Cheza kama Mluya. Luya's in the house, oye! Wapi mapeka.
Baba Mungu
Haya, tuambie Mungu asanti mabalozi wa amani. I'm an agent of peace. Tulijenge Kenya taifa letu. Mungu nifanye niwe chombo cha amani yako.
Duniani kote, Mungu nifanye niwe chombo cha amani yako. Nihubiri amani kwa Wakenya wote.
Wapi hizo? Kuja kwa jukwaa.
Niwe chombo cha amani yako. Nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako. Nihubiri amani kwa Wakenya wote. Kwa Wakenya wote.
Ningependa amani isambae.
Kwa Wakenya wote.
Ningependa amani isambae.
Kwa Wakenya wote.
Ningependa upendo usambae.
Kwa Wakenya wote.
We cameraman, focus kwa stage.
Usambae.
Kwa Wakenya wote.
Ningependa umoja usambae.
Kwa Wakenya wote.
Ningependa umoja usambae.
Kwa Wakenya wote.
Wow, let's appreciate each and every one of us kwa makofi mazuri. Asanteni sana. Thank you for your attention na asante kwa utii. Tunaweza keti. Sisi sote ni mabalozi wa amani. Turn to your neighbor and tell your neighbor, are you an agent of peace? Turn to neighbor, say neighbor, I am. Na isiwe tu ni midomo, alafu tukitoka pale nje wewe ndio mtu ya kuchokora. Mnajua kuchokora? Kama sisi ni mabalozi wa amani, itoke kwa mioyo yetu, because we don't have a spare country. We don't have a spare country called Kenya B. So where we are living is Kenya A. If we ban it, if we spoil our name, if we lose good neighborhood, we can go to Kenya B. Do we all go to Kenya B? Do we have a Kenya B? We don't. So let us safeguard our country. Mungu ametupa nchi nzuri sana iliyojaa mana, maziwa, nyama na asali. Na hakuna nchi nzuri kuliko Kenya. We are the best. Amen. Clap for yourselves because you're Kenyans. Choir.
Tuishangilie Kenya, taifa letu tukufu, Kenya tunayoipenda. Kenya nchi tunayoipenda. Kenya nchi tunayoipenda. Tunajivunia sana tukijiita wa Kenya, nchi yenye baraka. Kenya nchi yenye baraka. Kenya nchi yenye baraka. Kenya makao yetu ni nchi ya kupendeza. Kamwe hatutaiacha. Kamwe Kenya hatutaiacha. Kamwe Kenya hatutaiacha. Anayependa Kenya ni yule mwenye kutenda haki kwa watu wote. Mtu mwenye kutenda haki. Mtu mwenye kutenda haki. Na ukipenda Kenya ujitengane na mambo yenye kuvunja amani. Hatutaki matata Kenya. Hatutaki matata Kenya. Wenzangu, Kenya kipenzi chetu, hatutaiacha milele daima. Kenya kipenzi
kipenzi chetu, hatutaiacha milele daima.
Kipenzi chetu, nchi yenye upendo, hatutaacha Kenya daima na milele.
Kenya kipenzi chetu, hatutaiacha milele daima. Kenya kipenzi chetu, hatutaiacha milele daima.
Na tumeapa sote wananchi wa Kenya kutumikia Kenya daima na milele.
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
Kenya ni mama yetu, tena ni baba yetu, hatutaacha Kenya daima na milele.
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
na nikienda nje sitasahau Kenya, na nitabaki Mkenya daima na milele.
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
sitaiacha Kenya nchi yangu,
Mwana Kenya daima.
na nikienda ng'ambo nitarudi,
Mimi ni mwana Kenya daima.
sitadanganywa kamwe na wabaya,
Mimi ni mwana Kenya daima.
na majirani wangu nitalinda,
Mimi ni mwana Kenya daima.
sitaharibu mali ya wengine,
Mimi ni mwana Kenya daima.
wala sitapotoshwa na wabaya. Mimi ni mwana Kenya.
Daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
tuishangilie Kenya, taifa letu tukufu, Kenya tunayoipenda, Kenya nchi tunayoipenda, Kenya nchi tunayoipenda daima.
Nyinyi watu mnanishangaza sana. Mnanishangaza. Nyinyi wenyewe ndio mumesema ni mabalozi na mnaipenda nchi yenu ya Kenya. Alafu kwaya wanaimba tushangilie Kenya kama mumekaa chini. Uongo. Niliona wachache walisimama. Kwanza CHPs. Mnapenda nchi yenu? Mnaipenda? Wapi kelele ya nchi ya Kenya? Haya. Mwalimu ukubali tu ni kuombe. Tarudia tena wimbo wa tushangilie Kenya, kwa sababu huo wimbo nikikubaliwa ndio utakao mlete mama nao. Kwa hivyo nitaomba tusimame sote, tufanye majaribio ya vile mama taifa atakavyoingia na wimbo wa tushangilie Kenya, na tuimbe sote kwa pamoja. If you're sure that you love your country, sing it from the heart. Tushangilie Kenya. Kwaya, tafadhali.
Tuishangilie Kenya, taifa letu tukufu, Kenya tunayoipenda, Kenya nchi tunayoipenda, Kenya nchi tunayoipenda. Twajivunia sana tukijiita wa Kenya, nchi yenye baraka, Kenya nchi yenye baraka, Kenya nchi yenye baraka. Kenya makao yetu ni nchi ya kupendeza, kamwe hatutaiacha, kamwe Kenya hatutaiacha, kamwe Kenya hatutaiacha. Anayependa Kenya ni mwenye kutenda haki kwa watu wote. Mtu mwenye kutenda haki. Mtu mwenye kutenda haki. Na ukipenda Kenya ujitengane na mambo yenye kuvunja amani. Hatutaki matata Kenya. Hatutaki matata Kenya.
Shika roho yako sema.
Wenzangu, Kenya kipenzi chetu,
hatutaiacha milele daima.
Kenya kipenzi chetu, nchi yenye upendo, hatutaacha Kenya daima na milele.
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
na tumeapa sote wananchi wa Kenya
Wapisha ngwe na vigelegele za taifa letu la Kenya
na milele.
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
Kenya ni mama yetu, tena ni baba yetu, hatutaacha Kenya daima na milele.
Kenya kipenzi chetu, hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
na nikienda nje sitasahau Kenya, na nitabaki Mkenya daima na milele.
Kenya kipenzi chetu,
wapi shangwe na vigelegele.
hatutaiacha milele daima.
Wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
sitaiacha Kenya nchi yangu.
Mimi ni mwana Kenya daima.
Shika roho yako sema mimi ni mwana Kenya daima.
Mimi ni mwana Kenya daima.
Sitaharibu mali ya
Angalia.
wengine,
Mimi ni mwana Kenya daima.
na majirani wangu
Twende
nitalinda.
sote.
Mimi ni mwana Kenya daima.
Sitakubali mambo ya wabaya,
Mimi ni mwana Kenya daima.
wala sitapotoshwa na wageni.
Mimi ni mwana Kenya daima.
Wenzangu,
Tushangilie kwa furaha.
Hatutaiacha milele daima.
wenzangu,
Kenya kipenzi chetu, hatutaiacha milele daima.
tushangilie Kenya taifa.
Wapi shangwe na vigelegele za taifa letu la Kenya.
Tunayoipenda.
Daima.
Tunayoipenda.
Daima.
Kenya nchi tunayoipenda.
Daima.
Jipigie makofi unapoketi. Asanteni sana kwa utiifu wenu. I'm just happy kwa sababu tunapoimba, unajua hawa officers wetu wa Presidential Escort Unit wakati mwingi wao huwa wamekunja sura, wako busy wakichunga usalama wa rais na mama taifa, but I was happy to see them singing. See, they're also Kenyans. Yes, I'm happy my colleagues from Peu. I saw them dancing, I saw them singing loud. Na yule hakuimba tutaonana nyuma ya hema.
Olikwerwa ingombe, olikwerwa ingombe, olikwerwa ingombe mulai wa mama, ingombe konanga limbara, ingombe konanga limbara, ingombe konanga limbara, ingombe mulai wa mama, ingombe. Malumu shombo, shombo malumu, mulisinga mama, oh Mukongo. Malumu shombo, shombo malumu, mulisinga mama, oh Mukongo. Ulikwerwa ingombe, ulikwerwa ingombe, ulikwerwa ingombe mulai wa mama, ingombe konanga limbara, ingombe konanga limbara, ingombe konanga limbara, ingombe mulai wa mama, ingombe. Malumu shombo, shombo malumu, mulisinga mama, oh Mukongo. Malumu shombo malumu, mulisinga mama, oh Mukongo.
Sound check 1 2. Sound check 1 2. Shombo maalum ni shombo. Sound check. Endelea tu mwalimu, endelea tu mwalimu. Sound check. Ukaguzi wa mitambo. Sound check. Sound check. Tushangilie Kenya, tushangilie Kenya. Mwalimu, tushangilie Kenya. Niombe sote tusimame tafadhali kwa heshima. Niombe tumkaribishe mama taifa kwa makofi mazuri. Wapi shangwe na vigelegele za mama Rachel Ruto. Tushangilie Kenya. Karibu sana mama taifa. Just one stanza ili mama aweze kujiunga na sisi. Tushangilie Kenya sote kwa makofi. Wapi shangwe na vigelegele za taifa letu la Kenya. Karibu mama taifa.
Twajivunia sana tukijiita wa Kenya, nchi yenye baraka. Kenya nchi yenye baraka. Kenya nchi yenye baraka. Kenya makao yetu ni nchi ya kupendeza, kamwe hatutaiacha. Kamwe Kenya hatutaiacha. Kamwe Kenya hatutaiacha. Anayependa Kenya ni yule mwenye kutenda haki kwa watu wote. Mtu mwenye kutenda haki. Mtu mwenye kutenda haki. Na ukipenda Kenya ujitengane na mambo yenye kuvunja amani. Hatutaki matata Kenya. Hatutaki matata Kenya.
Nitaomba sote tuwe wima. Walio na kofia ambazo si rasmi, kofia za chepeo na kofia za urembo, tafadhali tuzitoe kwa ajili ya wimbo wa taifa wa Jamhuri ya Kenya na wimbo wa Jumuiya ya Afrika Mashariki. tukiongozwa na kwaya yetu ya SHA.
Mungu nguvu yetu,
ilete baraka kwetu, haki iwe na mlinzi, na tukae na udugu, amani na uhuru, raha tupate na ustawi. Mungu twaomba uilinde Jumuiya Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu, jumuiya yetu sote tuilinde, tuwajibike, tuimarike, umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Nitaomba tuwe watulivu kwa ajili ya sala. Tamuuliza Dr. Salim na Dr. Judith watuongoze kwa maombi mafupi ya kufungua.
Na tuombe. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Arrahmanirrahim. Maliki yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina as-siratal mustaqim. Siratal ladhina an'amta alayhim ghayril maghdubi alayhim waladdallin. Amin. Ewe Mwenyezi Mungu, mlinde na mbariki rais wetu. Ewe Mwenyezi Mungu, mlinde, mpe baraka, fanaka mama wetu wa taifa Rachel Ruto, aweze kutuongoza, atupe mapenzi ya mama, nchi yetu iweze kunyoka, nchi yetu iweze kupata ufadhili na uweze kuendelea vema. Tunakuomba ewe Mwenyezi Mungu uongoze viongozi wetu wote na taasisi zote zetu za serikali. Tunakuomba ewe Mwenyezi Mungu upe hili taifa letu afya lisilo na janga wala balaa. Mwenyezi Mungu tunakuomba barikie huu mkutano wetu wa afya, ili nchi yetu ipate afya, kaunti zetu ziwe kielelezo za afya, na nchi yetu iweze kuwa na afya na siha njema. Amin.
Let's pray. Almighty God, we thank you this morning for gathering us together. We want to thank you for the leadership of this country, our President, Dr. William Samoei Ruto, and today we have Mama Rachel Ruto. We thank you for her as a mother of this country, as one of us taking care of the mothers as we speak about a mother and a child and their health and how we can take care of them. Glory be to your name, and thank you for everybody who has gathered here, all the dignitaries and everyone. We thank you because you are God, and it's for your name we pray and believe. Amen. Thank you.
Kwa ruhusa yako mama taifa, naomba tuketi. Mgeni wetu wa heshima mama taifa Bi Rachel Ruto, waziri wetu wa masuala ya afya Mheshimiwa Aden Duale, katibu wetu Oluga, katibu wetu Muthoni, mkurugenzi wetu Daktari Amoth, gavana wetu Sakaja na magavana wale ambao wameandamana nawe, wageni waalikwa. Ni furaha yangu siku ya leo kumuona mama hapa. The first family is a very unique family. Waziri Duale, tumeachana na baba taifa jana usiku saa 6. Leo tuko na mama saa 2 asubuhi. Let us appreciate the family. Yaani baba anaingia na giza, mama anatoka na giza. Ni watu ambao wamejitolea kuhudumia taifa letu. We don't take it for granted, Your Excellency. Na hata ukirudi nyumbani mwambie Mheshimiwa Rais, we don't take it for granted. You've given yourself to the country and there's a reason for us to celebrate you. I'll give Shah Choir one piece, just one line, and then we bring the program on stage.
Akina mama zapendeza, heko kina mama, juhudi zenu za amani kote. Nipongezi, heko kina mama, nchini Kenya kazi za kina mama zapendeza, heko kina mama, juhudi zenu za amani kote. Nipongezi, heko kina mama, pongezi tele kwenu, taifa kulitenga, taifa kulinua. Kina mama hoye, Kenya yetu hoye. Pongezi tele kwenu, taifa kulitenga, taifa kulinua. Kina mama hoye, Kenya yetu hoye. Siwadhulumu kina mama, majukumu yao sio kidogo. Siwadharau kina mama, nguzo ya jamii Kenya. Siwadhulumu kina mama, majukumu yao sio kidogo. Siwadharau kina mama, nguzo ya jamii Kenya. Kina mama, pongezi tele kwenu, taifa kulitenga, taifa kulinua. Kina mama hoye, Kenya yetu hoye.
Thank you, Shah Choir. Wapi makofi ya akina mama jameni? Asante sana, juhudi zenu zinaijenga taifa. Thank you. Thank you, Shah Choir.
Kina mama, mwanga wa taifa, juhudi zenu za amani kote. Kenya hoye, miaka na mikaka, kina mama, mwanga wa taifa, juhudi zenu za amani kote. Kenya hoye, miaka na mikaka.
Tupongeze kwaya yetu ya Shah kwa muziki mzuri uliopangwa ukapangika. Mziki mtamu kama asali, laini kama zinga za farasi, chini ya mwalimu Nick Emodia. Shukran sana. Nafasi ya mama taifa nikubalia ni mwalike Daktari Isaac Bashir, ili kwa dakika chache tu aweze kutukaribisha na kutuelekeza katika ratiba inayofuata. Na karibuni sana katika sherehe hii ya machweo.
Thank you very much. Your Excellency, Mama Rachel Ruto, our CS Health and all Cabinet Secretaries, all protocols observed. Good morning. It's an honor and pleasure, Your Excellency, to have you here to crown what our His Excellency yesterday started, especially on the issue of mother and child. This nation is blessed, and it's blessed at the right time. We've been in the list of shame for a while, allowing our mothers and our babies to die from preventable causes, and we are now on track because the owners have taken over their responsibility, and we can see light at the end of the day. Today, Your Excellency, much as we are looking at Ewene, it's a day for service delivery, and therefore mine is just to lay the foundation on what is this session about. Service delivery is where health reform becomes real for the wananchi. Health financing, all the building blocks of the health system has been enumerated here yesterday. This session takes us from policy translated to the people and the communities. What are our policies impactful, our policies felt on the ground? We begin with mothers and newborn through the Ewene project. which was launched by our Excellency, the President, on 28th of May. Then we have health financing in transition into services, health financing in translating into services, the SHA, the digitization, and all the rest that we have been able to achieve. Allow me to say that we have spent about 17 billion shillings for maternal health after SHA was launched. And prior to that, we used to have only 4 billion shillings for maternity delivery services. So you can see the leapfrogging of the success that we are going towards. Kenya has significantly expanded also access to cancer and specialized care with oncology services at the national referral hospitals and 3 regional cancer centers in Garissa, Mombasa, and Nakuru, and chemotherapy services to over 14 other centers. Progress continues across the health system, and today we are here to showcase all that. But allow me now, therefore, to take us through lived experiences of different cases, one on sickle cell. We will start with the sickle cell success story from JOTRH. Dr. Misore will be presenting, and then we'll go to a lived experience on a maternal health that was saved, and a newborn that was saved, and then we'll go to success stories of our health facilities. So allow me to call now Dr. Misore to do the presentation on the sickle cell success story. Dr. Misore.
Every beginning starts with a moment, but a safe birth is never just one moment. It is the result of many moments working together. Every 2 minutes, a mother dies from pregnancy or childbirth complications globally. Sub-Saharan Africa, including Kenya, accounts for nearly 70% of these deaths. The first 28 days of life are the most critical for a child's survival and development. Approximately 92 newborns die every day in Kenya. Most risks for mothers and babies are preventable with timely, quality care. Saving mothers and newborns requires more than skilled hands. It requires systems that work. Skilled health workers, prepared facilities, essential medicines, strong referral systems, reliable data, government leadership, national commitment, quality care priority.
Every mother is so critical to the well-being of their family and our economy. And that's why, under the leadership of President Ruto, we are giving it high prominence that if we stop the death of a mother and a newborn, that translates into more human capital and our social cohesion in our country. And we have implemented the RRI accelerated program in the last 3 months, and we want to make sure that we use that for the MDS-RC to gauge what is happening at our healthcare delivery system. And this RRI is the tool that we use both for the short term and for the long term. It gives us a very impactful assessment of the whole ecosystem. Every woman, every newborn, everywhere is anchored in our RRI and is integrated also into our RAMCA and investment care, cascaded down to our 47 counties. That is the roadmap Kenya has set itself for, to make sure that no mother, no child dies, but every mother and every child lives and thrives.
Across the world, countries are accelerating action. Awareness is a global initiative spearheaded by WHO, UNICEF, and UNFPA. In Kenya, it is led by the government through a multi-partner platform. Every woman, every newborn, everywhere.
I commit to make sure that the right policies are in place, and at our country level, led by our governors, to make sure that their facilities are on the spot and they check that all that is required, from commodities to technologies to staffing, are provided for. So we are well coordinated in that plan. Kenya is ready. We are committed. We have made a deliberate effort, both in terms of providing resources, human capital, working with partners and donors and NGOs to make sure that Kenya becomes a leader in reducing both maternal and newborn child. We want to reach the targets that WHO has set to make sure that no mother, no child dies, but every mother and every child lives and thrives.
Change is possible when governments, partners, health workers, and communities act together. Kenya is accelerating action for mothers and newborns because every beginning deserves a chance.
That was a video to lay the foundation. The media team can now project the presentation for the sickle cell. Dr. Misore? You don't have it? Where is it? Please go ahead.
Okay. So I'm Dr. Brenda Misore from Jaramogi Oginga Odinga Teaching and Referral Hospital, where I practice as a pediatric hematologist. So today I'll take you through a journey of a sickle cell treatment at our center, which has transformed from treating complications to now preventing and treating and having advanced care of treatment for sickle cell disease. So sickle cell disease, as we know, is an inherited disorder that affects the red blood cells. And it's inherited, so it has to come from both the mother and the father. So that's how a child gets sickle cell if both parents have a trait of sickle cell. So we have approximately 14,000 children born annually in this country with sickle cell disease. And what you can see there is the areas in red are the 17 high-burden counties in this country, which are highly prevalent of sickle cell disease. So what is peculiar about these areas is that they're around the malaria endemic areas of the country. So what happens when a patient is diagnosed or inherits sickle cell disease from their parents? So this is what it means. They will present to hospital with recurrent painful crisis, frequent hospital visits. They have missed school days as they grow up. There's financial strain to the families. There are lots of mental health challenges, especially when they get into adolescent and young adulthood, and this is because of isolation, stigma, and this is usually just because of the nature of the disease. Because of frequent painful crises, they're not able to take part in the same activities as their peers. They're not able to meet their full potential as adults. And then there's risk of severe complications and early death. So what you see there, the swollen hand, is actually the first presentation of sickle cell disease. So before we were able to diagnose these patients, this is how the patient will first present, and this would occur at the age of between 6 and 9 months of age. So the other presentation you'd see is they come in with yellow eyes, which is a sign of jaundice, also a complication of sickle cell, and severe anemia, which was the leading cause of death in these patients because of the nature of the disease. So before the structured sickle cell services was strengthened at Jaramogi, many patients and families experienced late diagnosis, often after repeated illnesses in various low-level facilities, and by the time they come to hospital, they already have complicated disease. They had frequent emergency visits during the crisis, inconsistent use of preventive intervention. So what we have currently as a treatment for sickle cell is a disease-modifying agent, a drug known hydroxyurea. And because of inconsistent supply, most of our patients do not have access to this medication because of cost, one, and also availability at the lower level facilities. So there was also delayed recognition of complications from the lower level facilities, and this is because of lack of training of our healthcare workers on sickle cell disease as it is. The other burden to the families is the financial and emotional exhaustion for families because of repeated hospital visits and painful crisis. So where did we start from? So what has happened is in our hospital is we have a comprehensive care model, as at now we do newborn screening of sickle cell disease, and early infant diagnosis. So we screen these babies at birth and also at the first contact at the MCH during the 6-week routine visit for vaccine. And what we do after diagnosis is to counsel these families and link them to care for follow-up. So regular clinic follow-up and early initiation of the disease-modifying agents is actually beneficial for this patient to prevent the repeated hospital visits that we see. So the other thing we have in the facility is treatment in terms of hydroxyurea. And what we offer is both pediatric-friendly formulations in terms of syrup for the babies and also capsules and tablets for the other older patients. We also give transfusion support, and part of the prevention of complications is immunization. So we offer booster immunization to these patients after they complete their routine vaccination, childhood vaccinations. So what we also offer is education and also teamwork for multidisciplinary teams that need to take care of these patients once they get their complications. So what has the Ministry of Health done to support this? So we have introduction of newborn, early infant diagnosis into the maternal and child health booklet, and we expect all babies born in this country at the age of 6 weeks to have been screened for sickle cell disease, to be able to detect this disease early and to be able to link them to care, and so that these patients are able to live without complications. So what's, please. So what are we doing different in Jaramogi as a tertiary facility that serves as a referral center for the 4 high-burden counties in the Western region? So we have advanced red cell exchange transfusion, and the aim of this was to strengthen care for severe complications. So one of the most devastating complications of sickle cell disease is acute stroke. We saw most of our patients coming in with stroke, and the other complication that we saw was chronic complications, especially for the adolescents and young adults that have lived with this disease. So most of them will come in with repeated painful crises, making them unable to go to school or work, repeated episodes of anemia requiring frequent transfusions, and the facility acquired a machine, the Optia Spectra, which has helped us to be able to give quality care to these patients to improve the quality of life. JOTRH is the first public hospital conducting red exchange transfusion, and the first procedure was done on the 1st of September, 2025. So that was our patient 001, and up to now, for the last 11 months, we have done 11 procedures in the facility. So this procedure is fully covered by SHA, and our patients are able to access 3 exchange transfusions in a year, which is adequate enough for our chronic transfusion programs. So what can we do? What we can do is to make sickle cell a healthcare priority. So the early diagnosis for every child, every crisis should be managed promptly, every family educated on sickle cell, every clinician trained to pick up these complications in time, and to strengthen our system to bring us closer to a future where sickle cell disease will no longer mean despair to these patients, but hope for living a healthy life without disability. Thank you.
Thank you very much, Dr. Misore, for that success story. There are things that we can do, and there are many other hospitals that need to give the same services to our client. Your Excellency, our next stage is to have lived experiences from a maternal saved, a mother saved, a newborn saved, a sickle cell case, and 2 of our facilities. So I'll ask Dr. Juliet to give me the names, to call them here. They will be standing here and give their lived experience. Each will be 2, maximum 3 minutes. Thank you.
Your Excellency, the First Lady of the Republic of Kenya, Honorable CS Aden Duale, CS for Health, and all protocols observed, Allow me to moderate and lead this team of Iwene Blooms. This is a group that is selling courage, hope, and showing that we can actually save our mothers and newborns while we are doing everything we do in our everyday life. Allow me to call on stage Elizabeth Nabita, who's an RH coordinator from Kisii County. Welcome, Elizabeth. Dr. Felicitas Makoha, neonatologist and county pediatrician in Bungoma County, who will come and share the story of the 770-gram ray of hope. Next on stage will be Dr. Sura from Pumwani Maternity Hospital, an obstetric and gynecologist. Kindly welcome on stage to share your story. Next will be Nancy Kerubo Onchenku, who will share a lived experience as a mother saved, baby saved, and SHA did not fail her. Last on the list, but not least, is Tracy Acheng, who's a courageous speaker, sickle cell warrior, and an activist and lawyer who is willing to share her story on the sickle cell journey. Welcome, dear panelists. I'll start with the one by one. This is the Iwene quickfire. 2 minutes, share your experience, then we'll continue with the session.
Your Excellency, good morning. I am Elizabeth Nyabda from Kisii County. Today, Kisii County is doing 62 days of zero maternal deaths. What does this mean? Commitment and teamwork. So I salute the Kisii County leadership, the healthcare providers, and the partners supporting in maternal newborn health. In the spirit of Iwene, Kisii County leadership prioritized maternal newborn health services, and among the activities that Kisii County is doing is MPDSR accountability, whereby every week we sit and ask ourselves, why did mothers die, and what can we do differently so that a mother does not die? So among the gaps that we identified falls among the pillars of Iwene. The first gap was the breakdown in critical care services, where we had a breakdown in our ICU, breakdown in oxygen supply in our Kisii teaching and referral hospitals, and our leadership came quickly and repaired the oxygen plant, and we had the ICU equipment being replaced first. And the other gap was the gap of quality care, whereby we trained 32 healthcare providers in the month of June, and these healthcare providers added to the pool of mentors who were trained earlier, and they do weekly drills, weekly CMEs, and continuous mentorship, and this builds confidence to the healthcare providers so that they are able to manage emergencies that come. The other gap is on referral, whereby in every review, we had a gap of delayed referral being mentioned, and so the referral unit was tasked with the responsibility of accounting for every referred mother, every referred newborn, and they were able to give outcomes. We cannot be able to leave out the community component, where we have our CHPs referring our mothers from the community, and they do continuous follow-up to identify danger signs. Lastly, Kisii County has adopted the digital platform, whereby we promote our mothers with messages so that they are able to be promoted during pregnancy and postpartum period. So our call for action as Kisii County is to sustain the zero maternal deaths. If you are doing day 62, then we can do day 70, day 90, day 180, and at the end of it, day 365, whereby we'll have all our mothers alive, home with their babies to thrive. Thank you.
Thank you so much, Kisii County. We'll now welcome Dr. Felicitas to share her story.
Thank you, Dr. Juliet. My name is Dr. Felicitas. I'm a pediatrician with specialty training in newborn care. Today I'm here to share a story of hope of a baby who was born 770 grams. Because of the physiologic weight loss, the weight dropped to 500 grams. But because of the interventions that the ministry has put in place, supplying CPAP machines, subsidizing the cost of caffeine citrate that we use to prevent apnea of prematurity, and having comprehensive newborn care training, the team in Bungoma County Referral, headed by the neonatologist, myself, pediatrician, and neonatal nurses, were able to take care of baby fever until discharge when the baby was 2 kilos. So previously, such babies will be termed to be an abortion or a miscarriage. But because of the interventions that the ministry and the county governments have put in place, we have a lot of success stories of babies who are born extremely preterm, less than 1 kilo, surviving. What are the key issues that you have to put in place for these babies to survive? They have to be born in the right place. So our CHPs who are here, if you have a high-risk mother, make sure that she goes to the county referral hospital where she'll have access to these services for the baby to be able to survive. Let this baby not be born at a lower level facility and be transported cold to the facility, and by the time they reach there, they die. So I'm here to provide hope for families that have had babies lost at an extreme gestation, that now we have facilities in place to reduce deaths attributed to prematurity, which is the leading cause of newborn deaths. Thank you very much.
Thank you so much. I'll now welcome Dr. Sura from the largest maternal hospital in sub-Saharan Africa. Welcome.
Hi, good morning, everybody. Thank you for this opportunity to share on how Pumwani Maternity Hospital continues to lead the way in quality maternal and newborn health. As Dr. Juliet mentioned, we're the largest maternity in Kenya and sub-Saharan Africa. We do about 15,000 to 18,000 deliveries per annum, and that's looking at about 50 deliveries per day. We may have dropped a few in the last 2 years due to some industrial actions. But essentially, in the last 19 months, that is about 1.5 years, we've reported nearly near zero maternal deaths. This is not an accident. This is a deliberate effort in sustained investment in our leadership and workforce. Ewene is a framework of 10 pillars, and we really try to incorporate that in our care at the hospital. For example, when we talk about the workforce, almost to date, 95% of our workforce, that is nurses, midwives, and medical officers, have been trained in EMONC, that is the emergency obstetric and neonatal care, comprehensive newborn care, and even a relevant amount of workforce has been trained on point-of-care ultrasound at the bedside. So that means at any given shift, we have a specialized workforce taking care of patients. When we talk of Pumwani, we talk of not working in isolation, partnerships with our referral hospitals. We don't have the ability for an ICU right now, but we talk of partnerships with our sister hospitals and ability to access ICU care. So when we are unable to escalate care, we're able to refer in a timely fashion. We talk of respectful maternal care. That is one of the core pillars that we hold true to our hearts at Pumwani. No mother should suffer with no dignity. Partnerships, we're a hub of research. We partner with foundations and donors. We're able to now allow that to bring in technology and offer, for example, continuous CTG monitoring for all our mothers. And we've taken it a step further where this is AI enabled. We're also able to do preventive, early detection and treatment of postpartum hemorrhage, one of the biggest killers of our mothers. What more can I say? Pumwani is known by its volumes, but we're distinguished by our outcomes, and that's the Pumwani way. Thank you.
Thank you so much. Your Excellency will now change gears to lived experience. We have a mother who was saved, a baby who was saved. And here she is, Nancy Kerubo, to share her story. Welcome.
Thank you. All protocol observed. Hamjambo. My name is Nancy Oncheku. I'm here to present preterm moms. Ningeongea kwa Kiswahili ndio tuelewane na wamama wenzangu ambao wako nje. Nashukuru sana. My journey started nikiwa na 30 weeks wakati maji ilipasuka nikiwa kwa nyumba. Nikakimbia hospitali Mbagathi. Kufika Mbagathi nikapokelewa vizuri, nikadungwa shindano za kusupport lung development. ili waendelee kuniobserve mpaka wakati wa kujifungua ulipofika. Ila huwa wakati haukufika. Mtoto wangu alikuja mapema na 31 weeks. Nilikuwa nimetense sana kwa sababu kweli wamama ambao mko hapa mnaelewa kweli mtoto wa 31 weeks ni mdogo sana. She was so tiny. I was tense like, mtoto wangu kweli atasurvive, lakini kweli alisurvive, hata mnamuona hapa. Si ni ukweli? Nashukuru Mungu kwa sababu wakati alipozaliwa alipelekwa nursery A, akakaa 2 weeks Mbagathi, madaktari wakamshughulikia vizuri. Ilipofika after 2 weeks akawa na shida ya kupumua, akapelekwa ICU. Mtoto akakaa pale 2 weeks pia, nikawa nimetense, najua bili imeenda juu, nitalipa vipi, nikawa nimechanganyikiwa. Mungu ni mwema, madaktari walikuwa pale ni wazuri sana, walishughulikia mtoto wangu vizuri, na nikatoka hata nikaenda side nyingine ya kangaroo. Mtoto alitoka akiwa na 1.4 grams, nikienda kangaroo alikuwa na 1.6. Pale kangaroo ni mahali unaweka mtoto kwa tumbo akiwa vile amezaliwa, ili you bond with her na apate ile joto ya mzazi kana kwamba bado wako kwa tumbo. Tulikaa pale siku kadhaa, tukatoka. Tulipotoka pale hospitalini mtoto alikuwa na 1.9 kgs. Mnasemaje? The doctors, the nurses are doing good work. Changamoto ni kwa SHA. Wamama wengi hatuna SHA. Mimi nilipotoka nilikuwa na wasiwasi, nitalipa aje bill. It was more than 600,000. Ajabu ni kwamba nilipoenda kuuliza SHA niliambiwa my bill has been cleared. Si kulipa hata senti moja. Wamama ambao tuko pale nje, mnaonitazama, jipangeni vizuri. SHA inalipa vizuri, SHA inapokea wamama vizuri. Ukiwa na SHA usiwe na wasiwasi. Changamoto nyingine, mtoto akija mapema usiwe na wasiwasi, mtoto wako ataokolewa akiwa hospitalini, ataweka nursery, apate matibabu mazuri na atatoka akiwa mzima. Asanteni.
Asante sana, Nancy, for sharing your story. Next, I'd like to invite Your Excellency. We are aware that you're the global newborn screening advocate for our country. And Tracy, who's coming on board, will come and share her story of survival, courage, and resilience. Welcome, Tracy.
Thank you so much. All protocols observed. My name is Tracy Achieng. I'm 32 years old, and I have sickle cell disease. I'm here to tell you about a condition that I was born with. It means that it was a condition that back then nobody knew. So it is a very debilitating condition, meaning that we go through a lot of pain. But despite that, I am here, and I am here because of the support of my country. I recently, on 6th of August, went through blood exchange, which was supported by SHA. SHA ililipia hii mwili yenye mnaona. I was not like this before. So, and it is not just my body. There are other sickle cell warriors, such as Michelle Omulo. You saw her picture. There's Lindsay Berita and many others. So I would really, really say that we are grateful. Apart from that, I would also want to highlight that as sickle cell warriors, we need more support, especially when it comes to our vaccines. This is not just a luxury for us, because this will prevent us from going to hospital, because prevention is cheaper than admission. And even in my story, there's somebody that I cannot miss to highlight. There is Mama Dafala, the Kenya Blood Ambassador. Mama wa Taifa, I would like to just let you know our experience as sickle cell warriors while we get our blood exchange. I have to keep making calls. Unaweza nisaidia damu? Hapana. CS, unaweza nisaidia? I have to do this until I get 10 pints. That's not easy. If you've done sales, you understand. So Mama Dafala adopted me as a patient, and she's a Kenya Blood Ambassador. I would please ask the government to work with such ladies who have goodwill, or persons with goodwill who want to help sickle cell warriors, especially when it comes to blood, because blood is finite. And looking at my background in law, I would love to highlight that Kenya has the best policies. And one of the policies I would like to highlight is the newborn screening. I would like to sensitize and say that let us continue to implement it all round, because every implementation that is delayed has a name behind it. For example, we have Joe Mudukiza. He recently passed away. Joe was a well-known sickle cell warrior and advocate. He started the journey back in 2016 with Honorable Isaac Mwaura. And what Joe's journey brought forward is the need for mental health support, because unfortunately at some point, he really wanted to go to Berlin to get euthanized. So I would like to say, as sickle cell warriors, we are really celebrated because of our, brevity, but we never really ask, what is the cost that we pay to be brave like this? Let us get our psychosocial and mental health support. Asanteni sana, and I would also love to say that I would want to work for my country. In October, I'm going to the International Sickle Cell Anemia and Thalassemia Conference in London, and I would like to say and show them that SHA is working. SHA has universal health coverage. So mukinishika mikono, I will be very happy to show this. And asanteni sana CHPs, Embakasi Central Unit. My mother is one of you, Nyamavila. CHPs, you're the ones who can help us to implement this thing of newborn screenings, because you get into homes, you can say and tell, this home has people who probably have the condition, and any hospitali get the screening. Asanteni sana for holding my hand. Let us hold the hand of thousands more. Thank you.
A round of applause. Your Excellency, the First Lady, dignitaries in the room, maternal and newborn health champions, we have heard the stories. In every woman, every newborn, everywhere, we always face the sun. There are challenges, but let's also amplify the positive stories to encourage one mother and any newborn who cannot speak for themselves. Kindly let's give a last round of applause to our panelists as they leave the stage. Thank you.
Thank you very much, Dr. Juliet, for ably moderating that. You want to take a photo? Please come back. Thank you. Your Excellency, I also want to recognize our governors. Please join the photo. The governors in the house.
Yes.
Yes. I can leave my things here. Yes. Thank you. Thank you very much, Your Excellency, for that good gesture of warm motherly care. It's a milestone for these warriors to achieve this today. Asante sana. Next, we have it's my honor now, Your Excellency, to call upon our Director General to take the program from here, the Eweno Promise, turning commitments into lives saved. Karibu DG.
Thank you, Dr. Bashir. Your Excellency, the First Lady of the Republic, Mama Rachel Ruto, Cabinet Secretary for Health, on Aden Duale, Excellency Governors present, CEOs of our hospitals, senior officials from the ministry, our PSS, distinguished delegates, ladies and gentlemen, good morning. Your Excellency, I will take us through a few slides as to why the global community came with this every woman, every newborn, everywhere slogan. The reason was that progress towards ending preventable maternal and newborn deaths had stalled, and resources were now being channeled elsewhere. And what was the reason for this stall in progress? Basically, 5 things contributed to the slowness in terms of progress of accelerating reduction in preventable maternal and newborn deaths. One was the disruption caused by COVID-19. Both the non-medical countermeasures we put in place disrupted services. Number 2 was because of conflict. You saw in the earlier video that 70% of the maternal and newborn deaths happen in sub-Saharan Africa. And globally, the figure is actually 260,000 maternal deaths. 70% to 80% of that happens in sub-Saharan Africa. So conflict was a key driver in stalling the progress. Number 3 was climate crisis, either because we have floods and we have disruption in health facilities, or we have droughts and we have food insecurity, acute malnutrition follows, and definitely, usually the first people who get affected are pregnant mothers and children under 5 years of age. The 4th C is because of aid cuts. Cuts in overseas development assistance really disrupted services in especially low middle income countries. You saw the stop work order that was issued by the US government and how that disrupted health service delivery. And the 5th one, which we are all being accused of, is called complacency. We let the ball drop. And therefore, WHO, UNICEF, UNFPA came together to be able to galvanize the global community to shape the direction going forward. Next slide. So in terms of progress, this is where leadership, where the rubber meets the road. His Excellency, the President, took it upon himself and asked very important questions. Why should mothers and children die? Yet we have the technologies, we have the expertise, we have the resources to be able to prevent maternal and newborn deaths. And the way to be able to do this for us as a country is we went through a process, developed a process of our plan for Awene 2026-2028, and we decided to be able to focus on the counties that were underperforming. This is a total of 26 counties, and that is critical because that is where you can be able to quickly change the indicators. Countries which are doing well will continue to receive our support so that as a country we move forward together in the spirit of universal health coverage, ensuring that nobody is left behind. A child born in Lokichar in Turkana should have the same chance to be able to live and thrive like that one born in Nairobi or Lungalunga in Kwale County. So we came up with targets of the 90, so that 90% of our mothers can be able to attend at least 4 antenatal clinics, and 90% of the births ought to take place in a health facility. Your Excellency, in the first 90, we are on track, though we need to do a little bit of more work to be able to push. We are 72%, to be able to push that to 90%. In the second 90 of skilled birth attendants, nearly 9 out of 10 mothers in Kenya now deliver in a health facility. And that is covered by SHA. And therefore, one of the critical gaps that used to be there, which was financial access to healthcare services, has been removed by the directive of His Excellency the President to ensure that we allocate resources under the Primary Healthcare Fund to be able to support deliveries at level 2, level 3, and select level 4 services. What now we need to do, Your Excellency, is to be able to ensure that of the 9 out of 10 who deliver in a facility, they receive quality and respectful care so that we can be able to inspire all mothers to deliver in health facilities. Further, His Excellency the President committed to be able to support this Awene cause by allocating the requisite resources to ensure that the progress that we have made is sustained and consolidated. One was allocation for money to be able to procure critical health products and technologies, which have been spoken to by the experts from Pumwani and Bungoma, like caffeine citrate, magnesium sulfate, heat stable carbetocin, to reduce the known causes of maternal and newborn deaths. The President further committed to allocate more resources for family planning, as you were told during our visit to the exhibition booth, that investing in family planning can actually be able to reduce maternal mortality by up to 40%. And then we also, HE also made a commitment to be able to recruit 5,000 extra healthcare workers, nurses, and midwives who will mainly serve at the primary healthcare facilities. And we want to be able to invest more in primary healthcare facilities because investment in PHC facilities promotes inclusivity, equity, and mothers and children are the greatest users of primary healthcare services. Therefore, as a country, the leadership has spoken, the healthcare workers are seized, and you have heard testimonials from Kisii to Bungoma to Pumwani, what the healthcare workers are doing to be able to change this narrative. As a people, what we now need to commit to is to be able to optimize our resources that we have, make the right investments for the greatest impact. We will continue to shine the spotlight on the counties that are off track, because focusing on them will be able to ensure that we can be able to have a rapid reduction in preventable maternal and newborn deaths. And Your Excellency, these counties are mainly in the northern arid lands, the coastal belt, and in the lake region because of the problem of malaria, HIV, and poverty. We need to be able to maintain focus on subnational level so that as a country we move forward as one people, so that no one is left behind, and quality of care becomes very, very imperative in this process so that mothers can be able to receive quality and respectful care when they go for services. And finally, at the very end, families, communities, and one whole people must be at the center of this in terms of the plans we make, in terms of the policies we make, in terms of our implementation framework and accountability. The counties have seized this moment to be able to put in place critical accountability measures, including maternal perinatal death surveillance and response. And now that has been institutionalized literally across the 47 counties. And that is why you can be able to get reports of Kisii going for more than 2 months without a maternal death, Pumwani delivering more than 15,000 mothers without a maternal death. Your Excellency, we want to thank you most sincerely for adding your voice to this very worthy and noble cause to ensure that we end preventable maternal and newborn deaths. We have the tools, we have the expertise, and together, if we walk this journey, we should be able to make a difference before the 2030 SDG targets. With those few reflections, it's now my honor and pleasure to invite the peers to make the remarks and take over the rest of the program. Thank you.
Your Excellency, the First Lady of the Republic of Kenya, Honorable Cabinet Secretary Aden Duale, Excellency Governors, UN agencies here represented by WHO and all our other partners, county government staff, CECs, chief officers, all the Ministry of Health directors, CHPs, habari zenyu, na all our distinguished guests of this summit. Your Excellency, we want to appreciate you for taking a lead role in championing Ewene together with His Excellency, the President. Your Excellency, much has been said, and so I just want to mention that From an implementation perspective, we are also coordinating all hospitals at the county level and at the national level to ensure that the targets that the Director General have already placed before you are being implemented. We've had a number of meetings with chief officers of county governments so that we ensure that their hospitals are moving to ensure that even when we have the commodities at KEMSA, that they are ordering for them, but more importantly, that they are also training healthcare workers to be able to put all the machines and the products to use, as you have seen from Kisii, from Bungoma, from Pumwani, and from the beneficiaries. Your Excellency, I just like to recognize my colleague, PS, Madam Mary Mudhoni, just to stand and wave in the interest of time. And then with those remarks, I will invite Excellency Honorable Sakaja to give his remarks, recognize the other governors, and then we'll invite CS Duale.
Your Excellency, Mama wa Taifa, mpendwa Rachel Ruto, Waziri Duale, makatibu, magavana wenzangu. Leo tuko na gavana wa Nandi, Mheshimiwa Sang. Tafadhali tumpokee hapa Nairobi. Tuko na gavana wa Mombasa, ndugu yangu Abdul Somad, ambaye ndo mwenyekiti wa afya. He's the chair of health at the COG and is doing a good job. Na pia tuko na Governor Mudhomi Njuki, ambaye ni vice chair wa COG. And Your Excellency, I must say that a lot of the heavy lifting that was done when we were doing the health sector reforms from 2022 was spearheaded by Governor Mudhomi. He was the then chair of health at the COG. Him and Governor Waiguru did a lot of work. And so the rest of us now, the chair of health etc., are carrying on based on what Mudhomi did, and we really appreciate what you did. Your Excellency, distinguished guests, our CHPs, CHPs oye! Habari ya leo? Mko salama? Your Excellency, every woman, every newborn, everywhere has given Kenya a number that none of us in leadership can afford to look away from. Even as we celebrate the successes, every day we lose approximately 15 mothers and 92 newborns, many from causes we know how to prevent. And really allow me to acknowledge the presentations that have been made here before, the success stories that we have had, the issue of sickle cell. I'm sure when you saw the presentation from Jaramogi, TRH, you saw that there were 3 red places. There was the Nyanza and Western region, which I'm told is the malaria-prone region. Then there was a coastal area, but there was an island in the middle. That island is unfortunately Nairobi, but I'm glad to report that we're making strides. We set up our screening and treatment center at Kianda 42 in Kibra. We have screening in Mathare North now and at Ruta. And just for awareness for the mothers and the parents out there, I know our CHPs are able to direct people. It is good for them to know that we also have those services in Nairobi. But back to issues of every woman, every newborn, everywhere. I want to speak about how we will change these numbers that we've been told and give some examples from the capital city. Ultimately, our interventions on every woman, every newborn, everywhere will succeed, of course, county by county, facility by facility, household by household. The Ministry of Health, of course, leads with policy, but pregnancy happens in our communities, not at the ministry, hopefully. Antenatal care happens in our facilities. Deliveries happen in our maternity units. Emergencies arrive at our hospitals. And that is exactly where counties become central to the success of these initiatives. And I'm really glad even yesterday, the President acknowledged the strong partnership between the ministry, the national government, and the county governments in addressing this. There are 3 delays that we must confront for us to sort this out. The first delay is in deciding to seek care. Then there's a delay in reaching care and the delay in receiving care once a mother arrives. In Nairobi, we have structured our response around these 3 delays. The first delay we close is taking health care to the household. The first battle is won or lost before a mother even reaches a hospital. Nairobi has 7,820 community health promoters who I'm very proud of, working across our city. These CHPs are the closest link to our mothers. They promote early antenatal care, follow up pregnant women, identify danger signs, and connect families to health facilities. Before, we used to tell people to go to hospital. These days, we take the hospital to the people through our CHPs, the strongest cog in the wheel of universal health care in our country. And we must appreciate the community health promoters. I'm glad that now we have gotten cover, SHA cover, for all our CHPs. And we thank the President. I'm glad all counties have now gotten on board. I signed the check in State House. It was a big check to pay for 6 months, and Duale is paying for 6 months, and plus the issues of the stipend. And thank you for the kits. And we're waiting for the 90 days. Now it is 89 days for what they're supposed to get. The second delay we must close, Your Excellency, our First Lady, is making sure a mother can reach care. Identifying the emergency is not enough. A mother must be able to reach there when she needs it. Nairobi County operates a toll-free number, 1508, that dispatches ambulances and coordinates referrals. And just the other day, we launched with the President 922 for the National Dispatch Center in collaboration with the ministry. In the last 4 months, our system has handled 4,573 emergency alerts and referrals, about 38 a day. We're achieving a 98% response rate, and this is critical for every woman, every newborn, everywhere. 54.6% of all emergencies handled by ambulances are maternity and newborn cases. So Nairobi 1508 and 922 are not just an ambulance number, it is part of our maternal and newborn survival system. Then lastly, it is closing the third delay. What happens when she arrives? This is the most decisive responsibility that county governments have, because there is very little value in reaching the facility if the facility is not ready to save a life. That means having the medicine, having blood, having a functioning theater, having newborn care, and having clear referral pathway when higher level care is required. I want to really applaud healthcare workers across the country, nurses, clinical officers, doctors. I want to applaud chief officers in the county governments, directors of health, our CECs, led by my CEC here. The work that they are doing is where the rubber meets the road. Your Excellency, many people may not know why I am very passionate about issues of maternal mortality. And let me tell you, my late mother had lost 3 children, before my eldest sister was born. She had difficulty with pregnancy. So the first 3 died. After she got the first 3, she was told that she can have only 2. And of course, you know African men, they want to have a boy. So my firstborn sister was born, and Marie. My dad was happy, of course, that's a child, but my second-born was on the way now, the second-born. Then when the second-born came, Evelyn. Now, my mom had been told because with 3 losses, she can only have 2. But my dad said, lazima work. So he insisted. Now, I was born premature. And in the 80s, I think it was very difficult to get an incubator. I was asking Dr. Amoth, what are the statistics? And so because of that, I had to be taken to a different facility. I was in an incubator for a long time. And so And now I'm here, by the way. I didn't, I survived. And when I became governor, I realized that Nairobi had no neonatal ICUs at all. And that information was from my CEC, my chief officers, my teams. And I said, this story must change. We have just seen Nancy Kerubo here. That child is one of the products of our neonatal ICU in Bagathi that I made sure that we have. And in that Bagathi, we have kangaroo, and in many of our hospitals. When you go to the kangaroo, we have now encouraged men, the fathers, to also do kangaroo. That's your mama peke yake anafanya kangaroo, even the men. And whenever I go there, I encourage the mothers. I tell them, you know what? Don't worry if your child is born small. Even me, I was born small. Your child can become a governor, can become a lawyer, can become a doctor, just to give them hope in the community. Your Excellency, because of that, we have really scaled up healthcare in Nairobi. I am proud of the numbers. From zero, we have 23 neonatal ICU beds in Nairobi. We have 224 newborn unit beds in the last few years since I became governor. We have further expansion ongoing in Pumwani and Bagathi, Mama Margaret Uhuru Hospital, which has 8 theaters, Mama Lucy Kibaki Hospital. We used to hear negative stories about Pumwani every day. We have recorded 0 maternal deaths. And that is the biggest maternal facility south of the Sahara, north of the Limpopo, delivering close to 16,000. The numbers went down last year because of mambo ya for wafanyikazi, but it's around, I think, 80 a day, 50 to 80 a day. And thank you, Dr. Christine. I must acknowledge, Christine is the CEO of Bagathi Hospital. Dr. Saru is the one who spoke. Thank you. It's the same in Mutuini. It's the same in many of our hospitals. We have established 6 new maternity units in Ruai, in Kasarani constituency, in Riruta, in Dagoretti North constituency, in Pumwani Majengo, just here in Kamkunji constituency, in Kaloleni, in Makadara constituency, and 2 maternity theaters that are not there at Kayole 2. That is the lowest, the low level. Kayole 2 in Embakasi Central, and Madare North in Ruaraka. This is possible. So as I conclude, I don't want to take too much time. We also have, allow me to say, in Nairobi, in all our facilities, every county maternity, we have made sure there's heat stable Kabetosin to make sure that we strengthen our response to postpartum hemorrhage, as well as the intrauterine balloon tamponade that's used to control severe postpartum hemorrhage, where uterine massage has not stopped the bleeding. Your Excellency, I'm not a doctor, but when you become a governor, you must be a doctor, you must be a garbage collector, you must be a roads engineer, you must be a everything. You must be a lawyer. I keep saying you must have the mind of a CEO and the heart of a social worker to run these devolved units. Your Excellency, I'm happy. I'm told in July we got a child of 650 grams. Last July, 650 grams, but survived because of the NICU at Mbagathi. I'll encourage all my colleagues to keep doing that throughout. So finally, of course, it's financing the front line. Waziri Duale, you're a champion that this country appreciates. I don't know what you are doing in the Ministry of Defense. This is the real defense that Kenya needs. This is the real defense that Kenya actually needs. He has done great in the Ministry of Health together with my brother Oluga. Financing has sorted out so much for us through SHA. Financing the front line through facility improvement financing. Your Excellency, in 2022 in Nairobi, we were getting around 700 million for all my facilities, 125. This last financial year, I have closed at 2.6 billion shillings that is staying within those facilities to make sure we have 90% availability of medicines and laboratory services. Our facilities are now doing outreaches. We've conducted more than 120 outreaches and in-reaches every month, bringing preventative and curative services closer to communities. Every death must teach us something. Infrastructure and financing are not enough. We need more as leaders, accountability, which is why together with the ministry and DHA and the COG, every governor in Kenya has a dashboard where every day They can tell how many births took place in their facilities, how many deaths, if any, took place in their facilities, and the interventions to make. That information is right at everyone's fingertips. We hold weekly maternal and perinatal death surveillance and response meetings. I will not continue with the speech, but just to add one element that I think is important that we've started in Kibra constituency. Early childhood development doesn't start when the child goes to ECD. It starts when the pregnancy occurs. It starts at the point of conception. We've started training our fathers. And we've told our fathers, one, when you shout and make noise at the mother in the house, the child can hear. Ukiwa mtu wa kuleta vurugu na shida kwa nyumba, mtoto anaanza kusikia. How you treat your pregnant wife is very important. Siku hizi sasa, kwa ile maeneo tumeanza training, wababa wanaingia wakiimba. Wanaimbia wamama, ndio mtoto atokee mzuri. You don't want to affect the mental state of your child because of shida zako za mtaa. Si ni kweli? So wababa, hii naambia wababa, come to the hospital for the antenatal and see visits with mom. Sisi tutawatrain na uingie ukiimba. Sawa sawa? Wababa hoye. Wababa hoye. Mtaimba. Kama mjui wimbo wa kuimba mnitafute after this, nitawapatia wimbo. Maternal, the success is not just for mothers. It is both the father, the mother, and the community. Your Excellency, thank you for your commitment towards every woman, every newborn, everywhere. Okoa mtoto, okoa mama must be more than a slogan. It must be a national promise delivered by all 47 counties. May God bless all of you. I wanted to invite Waziri, but I want to ask for a favor. I know we are short of time. But kindly, if my Vice Chair of COG, who did so much work, you know, when you're dealing with the bills, when you're dealing with the governors from 2022, kindly, Mheshimiwa Mudhomi Njuki, please come make remarks, and then you shall now take it back to the ministry. Tupige Vice Chair. And by the way, Mheshimiwa Duale, Governor Mudhomi Njuki, the Chair of Health, Governor Sharif Nasir, the former Chair of Health, and the Governor of Nairobi, all went to a very good school. Down the road, on Ngong Road. Thank you.
Thank you, Governor Sakaja. We must appreciate that that was the right person to speak today on behalf of the governors, because we all live in Nairobi and we're in Nairobi. Your Excellency, the First Lady, the Cabinet Secretary for Health, Adan Duale, my colleague governors, and all protocols observed. I may not have much to say, just to appreciate that the last 4 years has been a journey that Kenya needed. We started with the reforms that we had with the 4 laws that were passed, which has been the brainchild of the Kenya Kwanza government and the leadership of His Excellency the President. Those 4 laws brought the reforms that we needed today to bring us to where we are. I cannot figure out a country without SHA. I cannot figure out a country without the CHPs that we have today. The awareness that we are talking about today, which started much earlier in a smaller fashion by the counties in form of MPDSR, has been nationalized and coordinated. The effort of both the national and the county government that brings the synergy to ensure that mothers don't lose lives or even lose the newborns is critical and is a product of that synergy that we have between the levels of government. The health sector would not have been at a better place today if we do not have the coordination that we have, that has brought together all the health workers, irrespective of the space they occupy, whether it is CHP, whether it is a specialist in the ward and in the theaters. That has been very critical to ensure that all Kenyans are bored in what we are striving to achieve as universal health care for everyone in Kenya. We want to make a commitment as the Council of Governors with my colleagues. Initially, health used to receive more or less the same equal funding with the other sectors in the devolved units. But today, every county spends or allocates approximately 60% of its total budget to health. And that tells you that in all the devolved functions that we gave the devolved units, health is at the top. It is at the summit. It is of critical importance because without that health, then all the other functions cannot be able to be performed. I do not want to overrate because it's not my day, but I want to make that commitment. Daktari Duale, that as we call you today, we are going to work with you to make sure that the coordinated effort that the ministry has already been able to initiate with us will realize the results that the Kenyans deserve. With those few remarks, I would like to take this opportunity to ask the chair of, with your permission, First Lady, the chair of health, to make just one remark, or just make a remark and invite the CSL. Thank you very much.
I think today is a day of being hijacked. Your Excellency, the First Lady, I think Governor Sakaja forgot to inform you as well that our next guest as well who we'll be having, the Deputy President, who was also in the same school with us. So there must have been something right about the school we went to. First and foremost, I want to congratulate. I've said this to you in person, Waziri, and to your PSs and to the heads of the different sagas, that congratulations for a very, very beautiful summit. It is truly an eye-opener, not just to us as industry players and movers, but also to the rest of Kenyans. Kenyans being able to realize what it is that their government is actually doing for them. The plans that were initiated based on the needs of the people till today where we are. So congratulations. It takes a lot of vision from a leader who sees a whole jigsaw puzzle in many, many different pieces. And for him to be able to put everything in place, especially when you have naughty children, and in a case like this, when you're being taken to court, when parliamentarians were not being able to understand, when, every single person, heads of facilities as well, in some instances, were not understanding what the concepts were. It has taken time, but today it is truly not just taking shape, but the fact remains, and it is an undisputable fact that SHA has been able to save lives. SHA has been able to save livelihoods on what it is that we do. I just want to add on something else, and I think it is important. We need to start having this conversation as well. The issue of early childhood does not begin when a child gets born or a child goes to school. I agree. A child actually, it's from conception. And this is scientifically proven. All doctors who are here will be able to agree that what it is that you do when a mother is pregnant has an impact. When you see levels of areas where crime is actually high, it is scientifically proven that what happened to that particular mother since the time she was pregnant and for the first 5 years, what it is that has been able to be done on that child. When we look at figures and we see that we are having babies that are born malnutritioned and severely malnutritioned as well, I think the conversation now needs to shift from the proposal that we should not only just be doing the element of treatment, but we should also be doing the element of ensuring that we do not have such cases happening in the first instance. And maybe proposal that we will be coming as a council as well, to work with the Able Ministry on matters to do with malnutrition and severe malnutrition on our children. I think this is going to go a long way, and something that will be remembered, hopefully, for those who are going to come over after 2032. They will continue the journey where we were able to live it. With those very many words, I think it's my job to now invite the Waziri, who is, maybe we need to give you a title, the Defense of Health. Karibu sana.
Your Excellency, the First Lady, Mama Rachel Ruto, the Council of Governors, led by the Vice Chair, the Governor of Nairobi, the Governor of Mombasa, I think I saw the Governor of Nandi, I don't know if there's another governor. And then we have the Chair of our Health Committee, Dr. Nyekal, our colleagues from both MOH and our county government, our valued frontline soldiers, community health promoters. Your Excellency, our First Lady and distinguished guest, this plenary brings us to one of the clearest measures of a health system performance. Whether a woman can go through pregnancy and childbirth safely, and whether her newborn receives the care required for that newborn to survive and to thrive. For too many families, that journey still carries avoidable risk. And today I want to say one of the reasons why maternal and newborn mortality is now becoming a national discussion is as a result of an encounter between our president and senior global leaders who raised with him and told him, Mr. President, you have done a lot, but you must address maternal and newborn issues in your country. And that's why, and I'm very happy, and I want to thank our governors. When we isolated and said that 26 counties with high burden when it comes to maternal and newborn mortality, today I want to report very success stories working with the governors, Nairobi, Kisii, Garissa. These counties are also learning from counties that are doing very well. Our counties are doing the MPDSR. They're going from one county to the other. I think last month they were in Garissa. And Your Excellency, Mama Rachel, a woman may develop very severe bleeding. She might have a very high blood pressure or even an infection, while her newborn may be born prematurely, like Governor Sakaja. And now, you know, if he tells you I was born prematurely from his body size, you'll ask whether his story is adding up, whether I expected him to be. But those who are watching us, premature birth is real, and it can produce a very strong, well-built governor like Governor Sakaja. So there is light at the end of the tunnel. But on May of 2026, our president launched Every Woman, Every Newborn acceleration plan. We were the first country, not in Africa, I think globally, to launch that. And what does that tell us? It tells us we must place maternal and newborn survival at the highest level of the national leadership. For us, we are very proud at the Ministry of Health and even our counties, that responsibility at the highest level is with President Ruto. And more importantly, the President backed his commitments with resources. Today, after consulting with the Council of Governors in our last summit, today, President Ruto's government has provided 4 billion shillings to all our health facilities, level 2 and level 3, where a mother will go walk in, deliver, fully paid by the government of Kenya within the primary health care fund. And not only for delivery, but for all the newborn care essentials. We have also provided, under the leadership of the President, 1 billion for life-saving maternal and newborn commodities. And KEMSA CEO is here. Dr. Wako, yes, with the full instructions that those commodities that will save a mother must be available in every facility in our counties, because it's paid for by the government under the leadership of our President. And that those essential products are for life-saving maternal and newborn commodities. Then the President's commitment was on 2.5 billion for family planning. And further, the government now is committing another 5 billion to make sure that we have the required human resource. So we're going to employ another 5,000 midwives and nurses in the next 6 months. Together, all these represent approximately 12.2 billion in investment towards accelerating maternal and newborn survival. Never before this has happened in our country. And has there been very high-level presidential commitment? No. I mean, I'm the Minister for Health. I am the 23rd Minister for Health since independence. So I had to read the notes of the 23rd ministers, including the 4th President of the Republic of Kenya, Honorable the late Mwai Kibaki. And when I have read the notes, no president has made this kind of commitment other than President Ruto. And I want to commit also myself and my team, PS Mudhoni, PS Oluga, the DG, and the whole team from the Family Planning Directorate and the other directors, that we commit in stewarding these resources to ensure that these resources translate into services, into results which they have been intended for, and maybe in another 6 months when we come back to a forum like this, we can see the numbers have gone down. Your Excellency, our First Lady, when a mother walks to a facility to deliver, she is not a patient. She goes to a facility to go and give us another life. And it's very unfortunate if that mother and the child dies. And that's why our healthcare workers, the products available, the facility infrastructure we are doing at our counties, as well enumerated by Governor Sakaja, is so important to our country and in saving mothers and newborn. Your Excellency, even within these interventions, we must continue to learn from where the system falls short. Through maternal and prenatal death surveillance and response, every maternal and newborn deaths must be reviewed to establish what happened, where the delay occurred, and what must be changed. A no blame and no shame culture is being advocated for. And this is to encourage honest learning, but we must review at the result in a very corrective action. By 2028, Your Excellency, we expect, as I conclude,
this connected approach that our country is having today to produce reduction in maternal and newborn mortality, to give us a stronger emergency obstetric and newborn services, to grant us more reliable referral networks, and above all, to give us a very consistent standard of quality care across all the counties. Beyond 2028, Ewene must live a permanent culture of readiness, of learning, and of accountability, so that every pregnancy is supported and every birth is given the best possible chance. Your Excellency, let me now thank you because you have sustained advocacy for health and the well-being of our women, the well-being of our newborns, and the well-being of the children and the families in our country, and how you have complemented government efforts and given Ewene an agenda of greater visibility. With you being here, with you being part of this discussion, and you have been doing it, this is a very privileged moment for us, that visibility, that momentum, and that purpose. We are proud to have you with us today in your capacity as an Ewene champion, and we deeply appreciate the leadership and the commitment you continue to bring to this very important national cause. Colleagues and delegates, it's now my honor and duty and privilege to invite our First Lady of the Republic of Kenya, Her Excellency Mama Rachel Ruto, to deliver our keynote address this morning. Welcome, Mama wa Taifa.
Tumkaribishe Mama Taifa kwa makofi mazuri. Jameni, wapi shangwe na vigelegele za Mama Taifa? Tumpongeze kwa makofi, shangwe na ngemi. Wapi ngemi ya kina mama? Welcome, Your Excellency.
Thank you very much. We may be seated. Honorable Aden Duale, Cabinet Secretary, Ministry of Health, Mudomi Njuki, my apologies, Vice Chairperson, Council of Governors, and Governor of Tharaka Nithi County, Johnson Sakaja, Governor of Nairobi County, Governors present, Principal Secretaries present, County representatives, our development and implementing partners, healthcare professionals, and frontline health workers present. Ladies and gentlemen, good morning. Every mother remembers the sound of her baby's first cry. It is the most honest sound in the world. Relief, joy, and terror, all in one breath. That sound is what we are here to protect. I bring you warm greetings from our President, Dr. William Samoei Ruto, who in officially opening this summit yesterday, reaffirmed his commitment to strengthening healthcare and improving the well-being of every Kenyan. In healthcare, a promise is not measured by the words we speak. It is measured in lives. It is the mother who walks home with her newborn, the premature baby who defies the odds, the patient who finally gets care when they need it most, not when it's convenient for the system. It is therefore incredible to join you for this important conversation, from promise to practice, delivering quality health services for every Kenyan. I relate to it because I know that feeling of sitting outside a hospital room and waiting for news. I know the prayer that a mother makes when someone she loves is in the hands of a healthcare worker. And that is why when we talk about healthcare systems, I not only hear the language of policies and numbers, I hear the voices of families. In every facility we strengthen, every healthcare worker we support, every service we bring closer to our people brings us one step closer to the Kenya we want for our children. A policy becomes meaningful when a mother feels safe in a maternity ward. An investment becomes meaningful when a newborn survives. A healthcare worker becomes empowered when they have the tools to save a life. And a health system becomes successful when a Kenyan does not have to travel hundreds of kilometers to receive care. Ladies and gentlemen, in May this year, we launched the Every Woman, Every Newborn, Everywhere, Iwene Acceleration Plan, where we made a promise that no mother, no child should be lost to something preventable. So we must ask ourselves honestly, how do we turn that promise into a daily reality? The answer is not complicated. It takes leadership, investment, skilled healthcare workers, reliable equipment and supplies, referral systems that actually work when a life is on the line. And above all, it takes accountability across all stakeholders in the healthcare sector. The numbers tell us how urgent this is. Kenya's Iwene framework estimates maternal mortality at roughly 355 deaths per 100,000 lives births, with neonatal mortality around 21 per 1,000. But I want us to remember, those are not just numbers. Behind every single one is a mother, a newborn, a family that carries that loss forever, and a community that feels it too. So we cannot be satisfied with progress. We must insist on impact. As a goodwill ambassador for newborn screening in Kenya, I'm encouraged by what the Ministry of Health has already committed to. Under the Iwene Acceleration Plan 2026-2028, we are expanding maternal health care coverage through the Social Health Authority, investing in essential maternal newborn commodities, family planning supplies, recruiting and redeploying thousands more nurses and midwives. Today, we have heard what happens when promise becomes practice. We have heard about Pumwani Hospital that has had near zero maternal deaths. This has been through strengthened systems and relentless focus on quality care. We have heard about a maternity team in Kisii that went a full month without losing a mother. For that team, that is not statistic. That is a month of families going home together. And we will hear about Mwai Kibaki Referral Hospital, where more than 15,000 people have been reached in their communities for screening. 15,000 opportunities to detect disease before it becomes a tragedy. These stories tell us something important. The Kenya we want is not an impossible Kenya. We have already seen glimpses of it. Our task now is to make those glimpses the standard. Ladies and gentlemen, let us build a Kenya where a mother does not have to be wealthy to receive quality care, where a newborn's chance of survival is not determined by the county in which they are born, where a health worker is not sent into a crisis without the tools to respond, where a family does not have to choose between seeking treatment and putting food on the table, where quality healthcare is not something we promise our people, but something they experience. That is the Kenya we must build. That is what moving from promise to practice means, and that is the responsibility we carry together. Let us not be the generation that simply made promises, but be the generation that kept them. Okoa mama, okoa mtoto. Save the mother, save the child. Thank you. May God bless you all. May God bless our great nation of Kenya. Thank you very much. Thank you for the great work. I wouldn't want to say more than this, Waziri, because this issue of mothers touches all of us. Let me stop there. God bless you.
Thank you so much, Your Excellency. With due diligence, I request Your Excellency to remain on stage. Taomba mama taifa kwa heshima, wengine tuketi tafadhali. Kwaya zetu, chukua nafasi zetu kwa wimbo wa taifa. Mama taifa, asante sana na tunakushukuru. Wewe ni chombo cha amani na kila wakati unatupa bega lako ili tuweze kuja kukuomba. Nitamuomba waziri wetu, chukua nafasi kwenye jukwaa, PSS wetu, Director General, governors wetu na wajumbe wale wako, ili tupate picha moja na mama taifa. Niombe mama taifa. Shukran sana kwa waziri wetu, PSS wetu, Director General na wale wote wanaohusika. Magavana wetu, shukran kwa kuja kuidhinisha upendo wenu kwa masuala ya afya na hasa kushinda na mama. Tunasema shukran za dhati. Picha ya mwisho mama taifa ni every woman, every newborn, everywhere. Tafadhali wale wako, tujiongee mbele, tujiunge na hiyo picha. Yeah, the rest of us can take our seat apart from waziri and his team. Magavana na wajumbe wanaweza chukua nafasi zao ili timu hii inayofanya kazi karibu sana na mama waweze kupata picha hiyo. Let's take our position. If you can balance. Wengine wapite nyuma, wengine wapite nyuma, tuje upande wa juu. Every woman, every newborn, everywhere. Ni furaha yangu kuona kwamba siku ya leo tumeanza siku na mama. Siku njema huonekana lini? Na ni kweli tumeiona siku njema. Tumpongeze mama kwa makofi mazuri. Shukran. Nitaomba sisi tuondoke, tumwache mama jukwani ili tuweze kumaliza. Na kabla ya kuondoka, nitaomba waziri asalie, waziri na PSS, waziri and the two PSS, niletewe token of appreciation for mama. The token of appreciation. Ni tunu tu ya shukurani kwa mama ili atakaporudi nyumbani aweze kujua kwamba Wizara ya Afya inamenzi na tuna kila sababu ya kusema asanti mama kwa kuwa kielelezo chema. When we have a caring mother like you, we'll go far. Let's appreciate that token of appreciation that has been received na mama taifa. Shukran. Shukran kwa kupokea tunu yetu. Mwenyezi Mungu akubariki na kila uombalo kwa imani upate kweli. Nitaomba waziri na PSS waweze kuondoka, mama atasalia. Niombe sote tusimame. Walio na kofia ambazo si rasmi na kofia za chepeo tuweze kuzitoa. Tutaongozwa na wimbo wa taifa na kwaya yetu ya SHA na kwaya yetu ya KEMSA. Wimbo wa taifa. Tumefika mwisho wa sherehe yetu asubuhi ya leo. Tumpongeze mama taifa anapoondoka. Ni furaha yangu na niombe wananchi tutasalia ndani. Niliwaambia mama akishaondoka baba anaingia. Kwa hivyo tutulie wakati wowote kuanzia sasa. Mheshimiwa Rais atakuwa tuketi tafadhali, tuketi. Asanteni sana. Kuwapasulia tu mbarika ni kwamba wakati wowote kuanzia sasa Mheshimiwa Rais na naibu wa rais wataingia. Kwa hivyo tuwe watulivu. We'll be receiving the president anytime from now. So choirs, tuendelee kupata burudani.
Kenya, hatutaki matata Kenya, wenzangu, wenzangu, Kenya kipenzi chetu, hatutaiacha milele. Kenya kipenzi chetu, nchi yenye upendo, hatutaacha Kenya daima na milele. Kenya kipenzi chetu, hatutaiacha milele. Wenzangu, Kenya kipenzi chetu, hatutaiacha milele.
Tafadhali tusiondoke, tusubiri kuwasili Rais na Mheshimiwa Rais. Tusiondoke tafadhali. Baada ya mama kutufungulia siku, atakuwa anajiunga nasi sasa naibu wa rais Profesa Kithure Kindiki na Mheshimiwa Daktari William Ruto. Wale ambao wanaenda kwa vyumba vya haja, twende kisha turejee. Tafadhali. Niwakumbushe tena, tunamsubiri naibu wa rais Profesa Kithure Kindiki pamoja na rais wetu Mheshimiwa Daktari William Ruto. Tafadhali tusiondoke, mambo bado. Kwaya, mwalimu niletee kwaya kwa jukwaa. Ni kwaya yetu ya SHA na kwaya yetu ya KEMSA.
Check on two.
Nirudie tena tafadhali, tusitoke. Tuendelee kusubiri wageni wetu wanapokuja. Tuendelee kusubiri. Wakati wote Mheshimiwa Daktari William Ruto, Daktari Profesa Kithure Kindiki watakuwa wanajiunga nasi. Kwa hivyo tutulie. Tuongezee sauti kwa hii mic. Sound check. Sound. Sound check on 2. Nipe hii mic. Sound check. Sound check. Sound engineer kule nyuma nipe hiyo mic. Sound check. Sound check. Sound engineer. Sound check on 2. Asante sana kwa utulivu wenu. Tuendelee kupata burudani kutoka kwa kwaya zetu. Kwaya yetu ya ni kwaya yetu ya ati Kemsasha. Kwaya yetu ya Kemsasha. Haya, hii ni Kemsasha. Oh, ni Sha Kemsa. Sha Kemsa. Haya, tupeni burudani. Mungu nifanye chombo cha amani yako.
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Palipo chuki na ugomvi nilete upendo, Wakenya wote waishi kwa upendo kwa kweli. Palipo chuki na ugomvi nilete amani, Wakenya wote waishi kwa amani tele. Popote palipo na utengano nilete umoja, Wakenya wote waishi kwa umoja kwa kweli. Popote palipo na mzozo nilete amani, Wakenya wote waishi kwa amani tele. Yelele yelele, Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Palipo njaa na mashaka nilete faraja, Wakenya wote waishi kwa upendo kwa kweli. Palipo mpaka ya kisiasa nilete umoja, Wakenya wote waishi kwa amani. Palipo vita na majeraha nilete amani, Wakenya wote waishi kwa amani. Palipo mipaka ya kisiasa nilete umoja, Wakenya wote waishi kwa amani. Baba Mungu, utembee sehemu zote za Kenya, nihubiri amani na msamaha, tutumie madaraka yetu. Baba Mungu, usafiri sehemu zote za Kenya, tukomeshe vitendo vya ukabila, tutumie madaraka yetu. Welele welele, Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Wakenya wote, ningependa upendo usambae, Wakenya wote, ningependa upendo usambae, Wakenya wote, ningependa amani isambae, Wakenya wote, ningependa amani isambae, Wakenya wote, ningependa umoja usambae, Wakenya wote, ningependa umoja usambae, Wakenya wote, ningependa amani isambae, Wakenya wote, ningependa amani isambae, Wakenya wote.
Shukran, tuendelee kuwa watulivu kama nilivyowaarifu awali. Tutasubiri wageni wetu kuwasili. Mgeni wetu Daktari William Ruto na pamoja na naibu wake. Na wakati wote kuanzia sasa, naibu wa rais Profesa Kithure Kindiki atakuwa anajiunga nasi. Kwa hivyo nitaomba utulivu wenu na asanteni sana wale ambao wamevitembelea vyumba vya haja, vyumba vya kubeua, ukipenda vyumba vya kibiolojia na msharejea. Asanteni sana. Tuchukue nafasi zetu tuketi. Tunapoendelea kuongoa na kuwapa miziki mizuri kutoka kwa kwaya yetu ya Sha Kemsa. Mwalimu, sijui unatupeleka wapi sasa? Aha, mwalimu ananiambia kwamba tujivunie Kenya kwanza. Kisha kama utaona ni vyema na kwako yapendeza, nipeleke Western, nipeleke Pwani, nipeleke Rift Valley, nipeleke kule upande wa Shamahoho. Haya. Kwa hivyo kwa sasa tunajivunia. Wewe ngoja mwalimu.
Tunajivunia Kenya nchi yetu, kweli yapendeza, kweli yavutia. Tunajivunia Kenya nchi yetu, kweli yapendeza, kweli yavutia. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Tazama porini simba anguruma, kifaru yu pale na ndege wa anga. Tazama porini simba anguruma, kifaru yu pale na ndege wa anga. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Ziwa la Bogoria kweli la shangaza, majini ya moto kweli ni ajabu. Ziwa la Bogoria kweli la shangaza, majini ya moto kweli ni ajabu. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Ziwa la Victoria linaunganisha Kenya na Uganda, Kenya na Tanzania. Ziwa la Victoria linaunganisha Kenya na Uganda, Kenya na Tanzania. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Mlima wa Kenya ni mlima wangu, waona barafu hata jua liwake. Mlima wa Kenya ni mlima wangu, waona barafu hata jua liwake. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Fika Mombasa, wito wa bahari, ogelea maji, jua tamu kuota. Fika Mombasa, wito wa bahari, ogelea maji, jua tamu kuota. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu, na wananchi wote ni sawa tu, wapenda ugali na sukuma wiki, na wananchi wote ni sawa tu, wapenda ugali na sukuma wiki. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu.
Kila kitu. Ha? Kila kitu. Wapi mposti hapa? Hapa kuna mposti? Haya, nafahamishwa sasa tunatembea katika eneo mbalimbali za Jamhuri yetu ya Kenya. Mwalimu ananiambia kwamba tunaanzia kule upande wa pwani. Tupate wimbo wa Kigiriama. Nikipata mdadisi wangu ananiambia kwamba ni wimbo ambao umechezwa na Mjerumani. Lakini kwa leo kwa sababu Kijerumani kinatuchenga kidogo, watatuchezea kwa Kigiriama. Kisha baadaye mwalimu ukiona ni safi utupeleke upande wa Nyanza. Twende coast.
Mungu wanifujira loli, karikose charo chose, inini chakugenja. Mungu wanifujira loli, karikose charo chose, inini chakugenja. Kuna swaloli, ila giro chakugenda kariko se charo chose inini chakugenda
kasikira kwaligisa kwenda kwana na kifwaloli
kuseliwe ilagiro inini chakugenda
kasikira kwaligisa kwenda kwana na
kifwaloli kuseliwe ilagiro inini chakugenda ini mlungu wanukose inini chakugenda kariko se charo chose inini chakugenda ini mlungu wanukose inini chakugenda kariko se charo chose inini chakugenda.
Thank you so much, Sha Kemsa Choir. Tunaelekea Nyanza. Sound check. Nilikuwa namnogonezea mwalimu akumbuke kwamba sound engineer check one. Mr. DJ, kwani kunaendaje? Sound check, sound. Nilikuwa namwambia mwalimu kwamba akipeleka Nyanza akumbuke hata ingawa Nyanza watu ufikiria ni the Luo community peke yake, akumbuke pia kuna Omugusi na kwa hivyo akituletea ni Waranono, pia utuletee kebwege kura mangaise. Mangaise kebingia kura. Kura magaise. Magaise. Magaise baba motendere na ngweso din din di. Ama tuanze na hiyo. Hiyo inakaa tamu. Ni Waranono. Twende kazi mwalimu. Solo. Huyu solo nimemsaidia na moja. Hiyo nyingine ifanye. Inafanya.
Ni Waranono Yesu ni Waranono. Ni Waranono Yesu ni Waranono. Orichona na keloni emsalaba dawarai momio. Ni Waranono.
Ni Waranono gwenyuone lamo ni Waranono. Ni Waranono jahera ni Waranono.
Nono jaler ni Waranono taya. Nono jaler ni Waranono taya. Ni Waranono taya. Ni Waranono taya. Nono jaler ni Waranono taya. Nono jaler
Atiyo ni ruodha mano bongona. Atiyo ni ruodha mano bongona.
Atiyo, atiyo, anatiyo. Oh no, 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 atiyo ni ruodha mano bongona. Oh no, atiyo, atiyo, mano bongona. Oh no, atiyo, atiyo, mano bongona. Oh no, jaya, jaya, jaya.
Any wara no na gwenye wane lama ni wara no no. Any wara no no jahera ni wara no no. No no jale ni wara no no jaya. No no jale ni wara no no. Oh no, atiyo, atiyo, anatiyo. Epolo wana miela miela, wana miela miela. Epolo wana miela miela kawadonjo, wana miela miela.
Sama Yesu telo mbele to wandu bange. Hallelujah.
Epolo wana yonga yonga. Epolo wana yonga yonga kawadonjo, wana yonga yonga lele.
Sama Yesu telo mbele to wandu bange. Hallelujah. Oh no, atiyo, atiyo, anatiyo. Oh no, atiyo, atiyo, anatiyo. Oh no, atiyo, atiyo, anatiyo. Oh no.
Jameni, mnataka kunaambia hata baada ya kuimbiwa hivyo vyote, hata simseme tu asante kwa makofi? Wacheni uchoyo. Makofi jameni, makofi mazuri. Asante kwa yetu ya SHA na vile vile KEMSA. Ni furaha yangu kuona kwamba tunaendelea vizuri. Nikiwaalika kwa utulivu wenu tunaposubiri kuwasili kwa mgeni wetu naibu wa rais Mheshimiwa Prof. Kithure Kindiki wakati wowote kuanzia sasa. Ratiba yetu itakuwa kama ilivyo. Tutakapoingia tutamkaribisha kwa furaha, tupate wimbo wa taifa, kisha ratiba yetu itaendelea. Aha, mwalimu tuelekea wapi? Hakuna vile mwalimu naweza nipeleka South Africa na hatujaenda Kisii. Si tuende Kisii kwanza. Kuna Omugusi amekaa mahali tu ananisumbua. Ona, hata ameanza kuja. Ona Omugusi. Unaona Omugusi ananiambia Mike, wakienda South Africa kama hatujaenda Omugusi atakazirika. Unaona mpaka anajileta mwenyewe. Aya, kere. Tuende kazi mwalimu.
Kebenya kura mangaise. Mangaise kebenya kura. Kebenya kura mangaise. Mangaise. Mangaise baba mutengera nyangwe. Maemba baba matongoro. Matongoro maemba baba. Maemba baba matongoro. Matongoro. Matongoro baba mutengera nyangwe so ding ding ding. Kebenya kura mangaise. Mangaise kebenya kura. Kebenya kura mangaise. Mangaise. Mangaise baba mutengera nyangwe so. Kebenya kura mangaise. Mangaise kebenya kura. Kebenya kura mangaise. Mangaise. Mangaise baba mutengera nyangwe so.
fungua. Check. Ale. 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 Ale.
ya kutupeleka kwa Omugusi. Sasa umeamua kwenda wapi? Munataka kwenda South Africa? Huh? Aya, endeni basi. Sound check.
Kuna synchronize.
Azisenze mutwele mukosi. Bawo kisosomanda. Bawo kisosomanda. Uitone mutwele muzima. Azisenze mutwele mukosi. Bawo kisosomanda. Ine sinjalu elite yunia. Nisolo ondi siso wi. Baitane lesibe. Bawo kisosomanda. Ine sinjalu elite yunia. Nisolo ondi siso wi. Baitane lesibe. Bawo kisosomanda. Ine sinjalu elite yunia. Nisolo ondi siso wi. Baitane lesibe. Bawo kisosomanda. Ine sinjalu elite yunia. Nisolo ondi siso wi. Baitane lesibe. Bawo kisosomanda. Bawo kisosomanda. Uitonu bakamba. Azisenze mutwele mukosi. Bawo kisosomanda. Bawo kisosomanda. Uitonu mutwele mukosi. Azisenze mutwele mukosi.
Check sound. 2 checks. Check.
1 2 1 2 1 2 1 2 moja moja mbili 1 2 majaribio ya sauti 1 2 3
Sound
1
check.
2
Sound.
sound check 1 2 majaribio.
Na zikisha maliza au zikisha kuwa fika mwisho, tuketi ili tuweze kuendelea. Kindly give me the mic at the dais. Check 1 2. Sound check. Thank you. Nitaomba nimwalike mfawidhi mwenzangu Bwana Alex kama ananipata. Ni mfawidhi kutoka ofisi ya naibu wa rais aweze kutusalimu na kutuomba kufanya mipango tunapoendelea. Alex, tafadhali.
Asante sana mfawidhi Mike Gitone kutoka ofisi ya Mheshimiwa Rais. Niwashukuru sana wote ambao tumeweza kuwasili kwa muda ambao unafaa. Tukitarajia muda wowote kuanzia sasa. Mgeni wetu asubuhi ya leo, naibu wa rais wa Jamhuri ya Kenya, Mheshimiwa Profesa Kithure Kindiki atakuwa anajiunga nasi na atakapo
Kwaya tuwe standby, tushangilie Kenya ili tuweze kumleta mgeni wetu, naibu wa rais. Ni furaha yangu kuona kwamba mmekuwa watulivu, na wale ambao bado wamesimama tuketi sasa ili tuweze kumlaki mgeni wetu anapoingia. Karibu Alex.
Jerusalema, omunzi ohanyayo. Jerusalem, 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 omunzi ohanyayo. Jerusalem, 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 omunzi ohanyayo. Sia kutangazelela. Jerusalem, 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 omunzi ohanyayo. Sia kutangazelela. Jerusalem, 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 omunzi ohanyayo. Sia kutangazelela. Jerusalem, 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 omunzi ohanyayo. Afrika, ae Afrika, oh libete. Ae Afrika, oh
Viongozi wanaendelea kujiunga nasi. Gavana wa Wajir na mwenyekiti wa baraza la magavana, naibu wake yuko pamoja na sisi, Gavana Muthomi Njuki, gavana wa Nandi, PS Oluga na wageni wengine, gavana wa kutoka eneo gatuzi la Kisii, Mheshimiwa wajumbe, karibuni sana. Hii ni ishara tu kwamba muda wowote kuanzia sasa tutakuwa tunampokea mgeni rasmi, Mheshimiwa naibu wa rais. Niombe kwaya tushangilie Kenya, na nitaomba sisi sote tuweze kusimama tujiunge na kwaya tunapoimba wimbo huo tukimkaribisha Mheshimiwa naibu wa rais.
Kenya tunayoipenda, Kenya nchi tunayoipenda, Kenya nchi tunayoipenda.
Mabibi na mabwana, tumkaribishe Mheshimiwa naibu wa rais kwa shangwe na vigelegele. Karibu sana Your Excellency uweze kutuongoza kwenye hafla hii tunapoelekea kufunga hafla hii. Tutasalia tukiwa tumesimama. Mike.
Anayependa Kenya ni yule mwenye kutenda haki kwa watu.
Tuimbe sote kwa pamoja, wapi makofi na shangwe za taifa letu la Kenya.
Mtu mwenye kutenda haki. Na ukipenda Kenya ujitengane na mambo yenye kuvunja amani. Hatutaki matata Kenya, hatutaki matata Kenya daima.
Nitaomba sote tuwe wima. Walio na kofia ambazo si rasmi tuweze kuzitoa kwa ajili ya wimbo wa taifa wa Jamhuri ya Kenya na wimbo wa Jumuiya ya Afrika Mashariki. Wimbo wa taifa.
Umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Taomba tuwe watulivu, tuongozwe kwa sala Daktari Salim na vile vile ndugu Murkomen. Tuwe watulivu kwa maombi.
Na tuombe. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Arrahmanirrahim. Maliki yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina siratal mustaqim. Siratal ladhina an'amta alayhim ghayril maghdubi alayhim waladdallin. Amin. Ewe Mwenyezi Mungu, tunakuomba linde, umpe afya na muongoze rais wetu. Tunakuomba umlinde na umpe muongozo mgeni wetu wa heshima leo, naibu wa rais. tuongozee viongozi wetu wote, tuongezee taasisi zetu za nchi yetu. Mwenyezi Mungu tunakuomba ipe nchi yetu afya na siha. Tunakuomba ibariki hili kongamano ili tuweze kupata afya nchini kwetu. Naomba yote kwa jina lako Mwenyezi Mungu. Amin.
Let's continue praying. Almighty God, we come before you this morning with thanksgiving in our hearts. We want to pray for His Excellency the President, Dr. Samoei Ruto. Thank you for his leadership. I pray for the Deputy President, Professor Abraham Kindiki. Father God, I pray that you may bless him, guide him, because he's our chief of case right now. I pray, Lord, for the leaders present, that you may bless them and guide them, give them wisdom to lead this country to the next level. I pray for this summit, that you may bless all the delegates that have come from the counties. Guide us, Lord, until we end this summit as we continue now. We pray all this, Jehovah God, believing and trusting in Jesus' name. Amen.
Kwa ruhusa yako Mheshimiwa Naibu wa Rais, naomba tuketi. Mheshimiwa Naibu wa Rais, nikubalie tu kwa dakika mbili kwaya yetu ya SHA na kwaya yetu ya KEMSA wana ujumbe kwamba sisi sote tunaalikwa kuwa mabalozi wa amani. Kifungo kimoja tu, Mwalimu Emodia, Mungu nifanye chombo cha amani.
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Palipo chuki na ugomvi nilete upendo,
ili Wakenya wote waishi kwa upendo wa kweli.
Palipo chuki na ugomvi nilete amani,
ili Wakenya wote waishi kwa amani.
Popote palipo na mzozo nilete amani,
ili Wakenya wote waishi kwa umoja wa kweli.
Popote palipo na mzozo nilete amani,
ili Wakenya wote waishi kwa amani tele.
Yelele, yelele,
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Kenya wote.
Tupongeze kwaya yetu ya SHA chini ya Mwalimu Nike Modia na kwaya yetu ya KEMSA wakiwa chini ya Mwalimu Vincent wanapoondoka uwanjani. Shukran sana, tukishukuru waziri pamoja na wote ambao wamehusika kuhakikisha kwamba idara zetu mbalimbali zina kwaya ambazo ziko imara hivi. Profesa Kithure Kindiki, Naibu wa Rais, mgeni wetu rasmi, waziri wetu wa masuala ya afya, Mheshimiwa Duale Aden, makatibu wetu ndugu Oluga na dada Muthoni, mwenyekiti wa jopo la magavana, gavana wetu Sakaja na magavana wote ambao wameshiriki siku ya leo, wajumbe ambao wako nasi siku ya leo pamoja na Director General wetu Bwana Daktari Amoth. Nikitambua itifaki zote na kuziheshimu, ni furaha yangu kuona kwamba mgeni rasmi yunasi hapa, na pasina kupoteza muda zaidi nitamwalika PS wetu wa lugha ili aweze kutuvalia njuga. Tumkaribishe PS wetu kwa makofi.
Your Excellency, the Deputy President, Professor Abraham Kithure Kindiki, Honorable Cabinet Secretary Aden Duale, Chair of the Council of Governors, Governor of Nairobi and all the governors present, our MPs, development partners, UN agencies, our staff from the Ministry of Health, and our staff from the county governments, all distinguished guests, ladies and gentlemen, good afternoon. It's my pleasure to welcome you to this session on the second day of the summit. Your Excellency, mine is just to brief you in very few minutes on what happened yesterday. Your Excellency, yesterday we had a plenary here where we opened the summit, laid the foundation, but also brought in the several discussions that were supposed to happen. And in the entire summit yesterday, the focus was on health financing. We also had a lot of discussions that went detailed into the social health insurance mechanism that we have, the social health authority claims, the SHA benefit packages, the revenue measures, issues around other investments, including the health infrastructure. Your Excellency, we also had a very detailed discussions on the digitization, and it became a huge enabler in terms of what has happened, particularly on the components of devices that have been given, the connectivity to internet for many public sector hospitals, and also the software systems. And we wrapped that with the use of data as a strategic asset. Your Excellency, we also had discussions that related to coordination between national government, county governments, and how we work together with our partners, multilateral and development partners. Your Excellency, this morning we came to the productivity of the nation, our mothers and our children. Her Excellency, the First Lady, Mama Rachel Ruto, was with us this morning discussing the issues that relate to mothers and children and the national agenda that is also being spearheaded by His Excellency, the President, that we call Every Woman, Every Newborn, Everywhere. Your Excellency, today we have combined 3 sessions to look at health workforce and how we move forward to establish a health workforce that is fit for the health system that we have reformed. We also will be discussing service delivery, how all of these components of healthcare financing, digitization, the healthcare infrastructure come together to the contact at the hospital level when patients seek care. And lastly, Your Excellency, is on the issues around commodity security and health products and technology. And Your Excellency, we are very privileged that you have joined us just for that session that combines those 3 strategic components of the healthcare system that we will delve in today. And later, Your Excellency, we will have a listening session in the afternoon. Your Excellency, we have had a very detailed discussion, apart from the plenaries, which we have been blessed to have His Excellency the President, yourself, Her Excellency the First Lady, Cabinet Secretaries, Principal Secretaries. We have also had 4 sessions that have been going on in parallel, and we've had an in-depth discussion, mainly at the technical level, and we have a very rich discussion. Your Excellency, having given that synopsis, now it is my pleasure to welcome the Cabinet Secretary just to introduce this session and take over the program, Your Excellency. Thank you, and welcome all of us to day 2 of the summit.
Your Excellency, the Deputy President of the Republic of Kenya, Professor Abraham Kithure Kindiki, Your Excellency, the Chair of the Council of Governors, the Vice Chair, the Chair of Health, and the many other governors, WHO Country Rep, Dr. Nema, colleagues from MOH, and colleagues from our county governments who work within the healthcare system, the chairs and members of the Health Committee of both Houses of Parliament, partners, donors, ladies and gentlemen, good afternoon. Your Excellency, my work is very simple. This session is bringing together 3 elements that make a very important contribution to the whole of the healthcare system.
And they truly perform in such a way that if they are not working, then the healthcare system is not working. And these are healthcare service delivery. What goes on in our hospitals and health facilities, the healthcare workforce, and Your Excellency, when I came to the Ministry of Health, the first day, you and the President gave me that task. I was not welcomed to the Ministry of Health. There was no red carpet. I found the gate closed by demonstrating healthcare workers. And on a light touch, I asked P.S. Mudhoni, because P.S. Oluga by then was not there. I asked P.S. Mudhoni, fine, I will come in, but how do I go home after my duty? And she told me, no, you can pass through Kilimo House. There's an exit. And I told her, I am not going to pass through Kilimo House. My official gate is the gate of MOH. So the first day I started addressing healthcare workers, demonstrating. They baptized me, but I was very happy last night. At least both me and the Council of Governors, one thing they have agreed is that the last 2 years, there were no, we have resolved as a government all the industrial disputes working with the counties, from the posting of internship to the CBA agreements to UHC. So healthcare workforce is another thing that we are going to have and discuss in this session. The third one, which is important, is health product and technologies. We must discuss and we must get a solution to the historical issue in our country that hakuna madawa katika mahospitali na zahanati yetu. So, Your Excellency, service delivery is where reforms reaches the mwananchi through a very dependable primary health care, emergency response, surgery, mental and newborn and oncology and specialized care. The health workforce provides the knowledge, the skill, the compassion required to deliver that care, while the health product and technologies ensure that health workers have the medicine, they have the diagnostics, they have the equipment, and the supplies they require. Your Excellency, these three elements are inseparable. A trained healthcare worker without medicine or a functioning equipment cannot provide quality care. Commodities and technology without competent personnel cannot also save lives. An investment in either of these is meaningful only when the result is in an accessible, safe, and timely service for the patient. The effective integration of all these is therefore very central and timely for one important person, which is the patient. The effective integration is therefore central to improving our healthcare outcomes. It will be protecting families from financial hardship, and above all, it will strengthen our public confidence in our healthcare system. Your Excellency, as you have remained central to the coordination of government delivery agenda, and if I'm given an opportunity, I can speak for the Deputy President. I have seen many Deputy Presidents. I have seen many Vice Presidents before the enactment of the new Constitution. I have worked with the Deputy President in the legislature. He was the leader of majority of the Senate. I was the leader of majority of the National Assembly. We worked with him in the security sector. He was the Minister for Interior, and I was the Minister for Defense. So the person sitting before us, just in one word, not his position, not where he comes from, not his county. Kenya has a very decent in terms of personality in the name of Professor Kindiki. And that's why those of us who work with him in cabinet, that's why today I expect him not only to talk about these three themes, But of late, he is the one who does the summary of government achievement and programs the last 4 years. So as he gives us the highlights of this keynote address before we go to the panel, Your Excellency, as you used to do, I want you to start your summary from yesterday's plenary of the President. And you end it with what you have for us today. As we go now, later, with His Excellency, the listening session. So you have the opportunity to do that, Your Excellency. And now it's my distinct honor and privilege, colleagues and delegates, to stand up as we welcome His Excellency Professor Kindiki, the Deputy President of the Republic of Kenya, to deliver his keynote address.
Tafadhali naomba tuketi. Thank you very much, my brother Aiden Duale. It is true we've traveled quite a journey, and I would also say the same about you. And the evidence is there to be seen, what you have done with the colleagues at the Ministry of Health to stabilize this very important sector. We needed a steady hand to help us navigate the issues in the health sector. Makofi kwa waziri wetu. Brothers and sisters, I think I've been asked to do 2 things. The first one I'll do now, then I'll sit down, listen to the high-level panelists that are going to help us navigate the issues, the 3 issues that the minister has spoken about, and the PS. And after the panelists are done, I'll come back for a less than 10-minute summary of yesterday and today. How you are able to condense 2 days program in 10 minutes, only Duale knows, because that is the assignment he has given me. But I'll try my best to do that. So allow me first just to set the stage for our panelists by saying the following, that His Excellency the President yesterday, in the morning and in the evening in the town hall, set out the direction of our national health reforms and the progress that we have made together as national government and county governments working in concert. My task during this session is much narrower than the President's overview that he gave us yesterday. I have been asked to focus on execution, on what must happen for the reforms in this sector to deliver consistently to the people of Kenya. And for that purpose, I invite you to consider a simple delivery equation, which is the right health workers, the equipment, which have the right products and technologies, and also delivery of the right services at the right time. Effective implementation requires a coordinated approach. I don't want to overemphasize the need for coordination. And I want to salute our brothers and sisters in the Council of Governors. Governor Abdullahi, the chairperson, and your team, we are very, very blessed to have this cohort among the Council of Governors. Between you and your predecessor, Governor Waigoro, the former chairperson, you have given President William Ruto and those of us in this administration support and unequivocal cooperation that could not have been possible without the right leadership at this Council of Governors. Let us appreciate our governors. So that coordination, I've been blessed to be part of that delivery by virtue of my work as chair of IBEC, which is the Intergovernmental Budget and Economic Council of the Republic of Kenya. And I'm again, in that role, I have had the privilege of working with the colleagues, ministers, members of the cabinet, PSAs in the various sectors, but also I have had the privilege of a very supportive Council of Governors who have made my work very easy. Again, let us applaud each one of us. So this coordination and cooperation has been very, very present. And the need for us to continue in that manner into the future is because if one part of the equation fails, then the patient will feel that failure immediately. A trained healthcare worker without medicine cannot treat. Modern equipment without personnel or maintenance cannot provide health services. Financing cannot improve health if the facility is not ready to deliver care. Therefore, colleagues, brothers and sisters, the health system performance is therefore not just the total sum of individual programs. It is the reliability of the complete patient journey. We need one healthcare system with the citizens at the center. I'll be speaking to this a little more in my summary because we need this health system must deliver to the people of Kenya. If we do everything else and the system is not serving the people, we will not have achieved the objective. County governments are central to the success of this reform agenda through the implementation of the universal health coverage, strengthening primary health care, because they control the facilities in this space, the health facilities, and they control the entire frontline implementation and service delivery, the CHPs and also all the facilities up to level 5. Ladies and gentlemen, distinguished guests, that journey should begin at the household and at the primary healthcare facility before illness becomes severe and expensive. The primary healthcare fund, as we were told by His Excellency the President yesterday, has received 27 billion shillings, has paid out 23 billion shillings to more than 9,300 level 2 and level 3 facilities. Unprecedented. Every time I travel out of town, every time I accompany the president out of town, they are telling us that the amount of funding that dispensaries, level 2, level 3 facilities are receiving has never been received. I went to a dispensary somewhere in Kericho, in Sigoit Soin, and the governor there, Eric Mutai, was with me. And the dispensary told us this week we have received 1.4 million shillings from SHA this week. And they say in the past we never even received anything above 100,000, 50,000 at most under NHIF. So that's where we are. And this is money, as we are going to see, that is going to be retained to improve service delivery in that dispensary. It's not going to be sent elsewhere. The financing, this financing has supported more than 20 million outpatient visits by 15 million Kenyans. We have also increased primary care networks from 2 in 2022 to 278 hubs spread across the country. The fund is functioning. The next question is whether every shilling improves the facility's readiness and the patient's outcome. We must measure medicine availability, waiting times, early diagnosis, maternal and child health outcomes, and completed referrals. Primary health care must become the dependable front door of our health system, close to the people, capable of resolving most health needs, and connected to higher levels of care when timely referral is necessary. In that connection, it is important to note that we are improving, or we have improved how we respond to emergencies through the SHA 922 Lifeline and National Ambulance Dispatch Center. Kenya now has one national medical emergency number. One free call to this number connects a citizen to a trained dispatcher, an available ambulance, an appropriate facility and financing required for evacuation and the first 24 hours of emergency treatment. We must now make 922 dependable in every county so that we measure performance through calls that are timely answered, ambulance response that is timely so that it can save lives, appropriate referrals, and lives saved. In an emergency, geography and household income must not determine who survives. The same delivery discipline must guide the National Equipment Service Program, NESP. NESP is strengthening diagnostic imaging, theater, renal, laboratory, and other specialized services in county health facilities. His Excellency, the President gave us the statistics yesterday, what kind of equipment, the value, and the program is ongoing, and it's across the country. Again, unprecedented. But equipment delivery is not the same as a service delivered. Our concern must be whether the equipment is functioning, whether trained personnel and consumables are available, and whether patients are receiving timely services. More than 500,000 surgical procedures and over 50,000 cancer care services have been supported through SHIF, the Social Health Insurance Fund, and Emergency Chronic and Critical Illnesses Fund, ECCIF. We must now build complete pathways in which screening leads to early diagnosis. Diagnosis leads to treatment, and treatment includes appropriate follow-up and rehabilitation or for optimum health outcomes. Our ambition is not to own more machines. It is to shorten the distance, the time, and cost between a Kenyan and the care that can save their life. None of this is possible without health workers. Since 2022, again, the national government, in collaboration with the county governments, we have deployed 24,000 healthcare interns across all 47 counties. We've sponsored 262 medical registrars for specialist training, and we have committed now to recruit additional 5,000 nurses and midwives. Internship must remain. And this workforce is now supporting the 107,000 CHPs that are on the front line. So you can see already the progress that we are covering on the issue of personnel and healthcare workers. Internship must remain predictable and properly supervised. But we must look beyond placement. National and county government needs one workforce plan connecting training, internship, recruitment, equitable deployment, career development, and retention. We must also train for the health system we are building, not the one we are leaving behind. That means stronger competencies for the future areas of healthcare service delivery, which include primary health care, oncology, surgery, anesthesia, emergency medicine, critical care, biomedical engineering, and digital health. A health system cannot perform consistently when its workforce is managed through periodic emergencies. Our health workers must be planned and supported as a strategic national asset. I repeat, again, commending the fantastic work under CS Duale and our team in health, the COG, through the chair and the health committee and the entire leadership. We must continue to make sure there is stability within our healthcare workers. We cannot have a useful and progressive delivery system if our healthcare workers are disrupted from work. So we must build on this progress, and we have no excuse, we have no reason, we have no justification to allow disruption of healthcare service delivery. I must commend also the leadership of the healthcare worker unions. They have been very reasonable, and you have supported both county governments and the national government to find win-win situations to avoid disruption of service delivery. For the avoidance of doubt, we, the government of Kenya, national government and county governments, treat you, our healthcare service providers, as a strategic national asset. Brothers and sisters, ladies and gentlemen, the second condition for reliable delivery is commodity security. KEMSA's order fill rate, as we heard yesterday, has increased from 40% to 91%. And we have supported as national government KEMSA with 1.5 billion shillings directly, and also provided support for them to access a line of credit to the tune of 10 billion shillings. The next stage is to build an end-to-end supply chain that anticipates shortages before facilities run out. National procurement, county obligations, distribution and facility inventory must become one visible and accountable system. I was there when KEMSA and DHA were updating the president on where we are, and I think where we need to fine-tune now is the integration of the digitization process in KEMSA with the Digital Health Agency medical health data, so that it's one seamless. You know, you cannot have a digitized supply chain data that is separated from mainstream healthcare data. So the two are interlinked. So we need the two systems to speak to each other. And the supply chain and commodity supply chain data to be part of the whole under DHA. In the longer term, Kenya must manufacture more of the medicines, diagnostic medical devices, and offer products that we consume. Local manufacturing will secure our supplies, create skilled jobs, support innovation, and convert health expenditure into domestic economic opportunity. The reforms are in place and the investments are being made. What is now required is disciplined coordination across national government, county governments, agencies of government, providers, training institutions, partners, including implementing partners. We should leave this session today with a compact set of performance measures: facility readiness, equipment uptime, medicine availability, workforce coverage, waiting times, referral completion, patient safety, and health outcomes. Digitization must be the performance enabler that connects the patient's journey, gives us real-time visibility of health workforce, commodities, equipment, and referral pathways that enable timely correction and accountability wherever the system is off track. These measures should be visible by both the facilities and county governments. Strong performance should be recognized and shared. Persistent underperformance should trigger support, corrective action, and accountability. Our objective is straightforward: a health system that works the first time, works in every county, and works for every Kenyan. That is how we will move from policy pronouncement to programs, to performance, from investment to value, and from the promise of reform to reliable healthcare delivery. Thank you very much. I will be back with a summary, which should not take more than 10 minutes. I just thought I needed to make a pitch for all the issues and for the record of this conference to read a speech. Otherwise, when I come back, I will not bore you with reading any speech. Thank you very much.
Thank you very much, Your Excellency. Thank you very much. We may be seated. Your Excellency, allow me to practice. You know, you want us to be comprehensively competent. So before I call the panel, I just want to ask the crowd, Deputy President wetu ni fire si fire? Ni noma si noma? Summit ni fire si fire? Ni noma si noma? Your Excellency, you know I have to practice for a possible career. Your Excellency, at this juncture, with your permission and that of the Honorable Cabinet Secretary, allow me to call our panelists. I'll begin with the Vice Chair of the Council of Governors, His Excellency Muthomi Njuki, who is also the Governor of Tharaka Nithi. Please join us in this high-level panel discussion on HRH, HPT, and service delivery. I will also call on stage the Chair of the Committee of Health at the National Assembly, Honorable Dr. James Nyikal. Please join us. I am trying to look for Dr. James Nyikal. I will also call on stage the CEO of the Kenya Medical Supply Agency, Dr. Warko Ejesa. Please join us on stage. We have the chairman of the Healthcare Federation, Kenya Healthcare Federation, Dr. Gakombe. Please join us on stage. We also have representative of the UN agency, Dr. Neema Kimambo, who is the country representative for WHO. Please join us on stage. Yes, I can see Honorable Dr. Nyikal. Yes, and I will also call the CEO of one of our hospitals, Dr. Richard Lesiampe. Please join us on stage. And for the National Assembly, before we have Honorable Nyikal, who was around, I think we have a member of the Health Committee, Honorable Dr. Robert Bukose. Please, you can stand in for Dr. Nyikal. And Your Excellency, as the panel settles in the questions, just as a prelude to the discussion on HRH, we have a State Department established for the first time in this government on professional standards. So allow me to call Madam Mary Muthoni just for a 1 minute discussion on what this State Department has been able to do. Thank you.
Thank you very much, Daktari, Your Excellency. Karibu sana for our summit. Mine is just going to be a wrap-up of what generally we look at when we talk about HRH, or Human Resources for Health. And one of the key areas, and I know His Excellency Governor is going to talk about, is the requirement to deliver the right numbers. That is why the government is continually employing. Just the other day, we have been able to transition our UHC staff from contract to permanent and pensionable, and the counties every other time are employing to ensure that our facilities have the requisite numbers to treat the people of Kenya. Again, we are also talking about delivery of the right skills. From the State Department of Public Health, I keep telling the healthcare workers, niko na pesa ya kukupeleka shule. You only need to apply so that we can take you for postgraduate training. So do not just stay with your one degree. We can go and take you for specialized skills so that when you go back to your facility, you can add more value. We are talking about equitable distribution again. Just before we came in, we were talking about what we are going to do to get the needs assessment for the whole country, so that we are very clear on who we require in every county and every corner, and in all facilities. As we also send you for postgraduate training, we will be very keen to know how many OBS-GYNers are in Tharaka Nithi County versus the ones in Mombasa County as equivalent to the population. Then the fourth thing that we are going to listen to is the delivery of decent work and productivity. Management must address workforce challenges such as unemployment of trained professionals, issues to do with faculty gaps, issues to do with attrition, migration. And I am sure these are gaps that we have continually tried to address as we look into the structural limits, and that must be navigated while protecting the worker rights, safety, and also the well-being of our healthcare workers. And finally, deliver on the data-driven accountability. The whole of this summit, we've been talking about data, because data does not lie. And when you have the right data, you're able to also plan for the future. So Kenya has demonstrated a very growing capacity for evidence-based planning, ranking third in Africa, and also sixth globally in national healthcare workforce accounts, reporting with 92% data availability. So with those few remarks, I take back the mic for the panel.
Thank you, Madam PS. And now we go straight in, which will be like a quick fire of just 30 minutes. And we begin with Your Excellency, Governor. The Constitution decentralized service delivery and established counties as the responsible level of government when it comes to management of health. Looking at where we have come from and the reforms that we have established, how do we enable coordination that ensures that national government, county governments strengthens service delivery at that level? And as you answer that question, you may also talk broadly about county public service boards and the role that they can play in strengthening health workforce component as a part of health systems. Excellency, please proceed.
Thank you very much, PS Oluga. Of all the resources that we have put together as a government of Kenya to bring the health sector where we are, the most critical one is human resource, which sometimes we normally put at the bottom of the pyramid because it is a moving target most of the times. as compared to all the other resources. It is possible for you to be able to tell how many drugs you've been able to move from KEMSA. You're able to tell how many equipments. But the management of human resource is so delicate because we are dealing with human beings who sometimes have responsibilities beyond the work that they're in. I say that because since devolution, which was supposed to bring services closer to the people, we've seen improved number, or rather we have seen number of health workers increasing in the counties as compared to before devolution. Not just increasing in number, but also in terms of quality and terms of representation. And to give you a perspective on that, remote counties in Kenya before hardly used to retain very specialized health workers, especially the ones in the cadre of the ones we normally call the specialized consultants, where you find a remote county like Turkana used to have only 2 consultants. And those ones would hardly be permanently there because they have calls, maybe in the hospitals in Nairobi over the weekends, so they are in Turkana Monday and Tuesday, Wednesday they move. But since Turkana, I'm just giving Turkana as an example because we have the data that is amazing. Since we are given the responsibility to recruit, retain, motivate, and ensure that these specialists are meant for the Turkana people, they have seen the numbers rise from around 2 to over 20 specialists who are highly motivated, who are retained, and the Turkana people get value for their money. It is the same case across all the counties. Because when you manage your health workers, it is possible for you not just to monitor, but also have a responsibility as a team without being coordinated from somewhere else on your duties to be able to deliver. Secondly, we have seen increase the number of health workers in all counties since devolution. The number of nurses have increased, the number of clinic officers, the number of MOs. It is not just because of coordination, but because of deliberate effort by the leadership of the counties to fill in the gaps and also to adhere to WHO standards of the 5-kilometer radius of a health facility. And because of that, our patients are traveling shorter distances now to receive that care. Not just only to receive the care in the facilities, but for specialized, well-motivated healthcare workers who would usually respond to their needs. Do we have a challenge? Of course we do. One of the major challenges in that space is always having inadequate staff. Not because you don't need them, but because the capacity to hire them may be limited by the resources available. And even when the resources are available, we are limited by the established structure of the workforce, because we have a formula that does not allow you to have over 35% of your resources going to personal emoluments. So if you want to employ more staff in health sector and you need them and your physical space cannot allow it, you're only left to distributing the ones you have very thinly because you cannot ask for more resources unless you generate. Thanks to what is happening now in the space of health, since we had the reforms and the 4 laws that we passed, we have more resources now being generated through reimbursement of SHA, and with the facility improvement fund, we now have more resources that are available. But is it possible to direct those resources to employment? At the moment, I don't think the structure allows that. We plow that back to improve the facility. Does the facility improvement include employment? That is a good question we should be asking ourselves on the way forward, because that is also a need.
Thank you, Excellency Governor. I know time is limited, but I wanted you to comment on the intersection with the county public service boards. There are a number of counties that occasionally we find the county public service boards needs a bit of strengthening. The Constitution talks about the advisory role of Public Service Commission, but then how do we engage so that then service delivery is not interrupted?
The County Public Service Board have played a very critical role in recruitment, in ensuring that we don't just recruit, but to have the right staff with the right skills and also being placed in the right places. And you are aware that even in the coordination that we have with the national government, the MOH, on the staff that we have shared responsibility, like the UHC, the recruitment was by the County Public Service Board, even though the payroll has been domiciled in MOH. Without the County Public Service Board playing the right role, we would be having these workers being somewhere in between without direct responsibility and supervision. Yes, it is true that we need to kit, or rather to continuously build our capacity for Public Service Board, because they may not currently be at the same level of Public Service Commission. But a lot of work has gone into capacity building, and we are seeing proper interpretation of policies from the MOH, and also in Salaries and Remuneration Commission, and also from Public Service Board, that have made the counties also be units of higher standards of professional recruitment in the workforce.
Thank you, Excellency. A round of applause for Excellency Governor. Now, on the same note of HRH, before we move to service delivery, we work with WHO at the Ministry of Health, and there are two key documents where the leadership led by Honorable Cabinet Secretary Aden Duale has been pushing us that we must have a health professionals policy. And this relates directly to how we galvanize the management of health workers from training. I know that WHO has had some input to the Ministry of Health, and as you mentioned, the role of WHO in intersecting with national governments that are member states of WHO in establishing policies for health professionals or even health workers. You may also comment on the Health and Care Compact, which is also another tool that involves a framework for enabling countries to clean up, let me use the word, clean up the space of health workers, because it's been a big challenge, including the code of practice for international recruitment of healthcare workers, just so that we wrap up that session on the health workforce.
Thank you very much, PS and Excellencies. I'll stand on existing protocol. So WHO has been working with the Ministry of Health on health workforce with support from the UK government. And I just want to highlight several tools that have been very useful. WHO has a tool called Health Labor Market Analysis, which enables the country to look at the different cadres they have, where they're placed, and look at the needs. And this health labor market analysis helps to look at the training, the production, and all the different cadres that you have and the needs of the country to enable the country to be able to plan with evidence for the health workforce. Another very important tool is the National Health Workforce Accounts, which helps the country to really come up with data of all the health workers they have. And prior to using the National Health Workforce Accounts, maybe we had numbers that were just at national level, but now we have detailed data that even counties, all the 47 counties, are able to see all the health workers that they have and where they are placed. And this is important because you're able to see the gaps, and you're able to see where it is most important and where the gaps are, so that you place, as you recruit, that you place them in the correct places. And this was what P.S. Muthoni alluded to, that Kenya was ranked 3rd in the region and 6th in the world in terms of data. Another important tool is the workload indicator staffing need. This helps managers to be able to look at the load that the health facility is covering, what types of patients are coming in, and this then guides them to be able to plan appropriately based on the need of health workers. So we have been able to work with the ministry on this, and for the first time, the ministry has now come up with a health workforce policy and also a health workforce strategic investment plan. And at county level, about 130 managers, HR managers have been trained on this workload indicator staffing need, which will enable us to plan better in ensuring that we put health workers where they are most needed. And this brings in now the African Charter, which aims to ensure that we train, that we deploy, and that we retain health workers where they are needed, and to be efficient in our placement of health workers, because sometimes you can have the numbers, but you may have huge numbers, maybe in Nairobi, for example, and there's duplication, and you have other places which are more remote, which are lacking the services. This health labor market analysis also informs what P.S. Oluga has alluded to on the International Code of Migration of health workers. You are able to see what is your output, and are you able, countries are labeled according to their production, according to the staffing that they have, to see whether they can export health workers. Now, if you export health workers, what has been happening previously was in countries with good training, quality, you would have health workers being taken by developed countries, but the country that has been producing those health workers is not gaining anything. So at WHO, we work with countries to have, as they come into agreement with developing nations, as they are taking staff, that you have an organized migration, but you also get good contracts for those who are going, but also what comes back to the country, because the country has invested in training these people. So if they are going abroad, if you're producing more than you can use, but what is the country gaining? So WHO has been working with several countries, as well as, I know, Kenya, Ghana, Nigeria, and others in terms of helping countries to negotiate for this organized migration where needed. Thank you.
Thank you, Dr. Neema. Your Excellency, if you allow me, that the issue about the co-investment that WHO talks about is important for Kenya, because I know this is also one of the key agenda of our government. And I just wanted to ask for a roving mic, Your Excellency, just so that we get the numbers from KMTC in terms of nurses and those who are going abroad, so that then we can look at how to engage in this co-investment decision. And this is important for your leadership. So the CEO of KMTC, just a 1-minute comment on those numbers and how they have improved. Please, roving mic, CEO of KMTC is right here.
Thank you so much, Your Excellency. My name is Dr. Kelly Olwach, CEO of Kenya Medical Training College. Your Excellency, in 2022, we were graduating 15,000 students. In 2025, Your Excellency, we graduated 22,776 students. Your Excellency, that is an increment of 43%. Your Excellency, this year, we are going to graduate 25,000 students. Your Excellency, one of the efforts that we need and very critical for us is responsible labor mobility. Your Excellency, as an institution, Kenya Medical Training College has created foreign language curricula in German, French, and Arabic, and now Amharic, to support labor migration. What Madam Nema is talking about is critical for Kenya Medical Training College because we are the largest producer of human resources for health in this country and sub-Saharan Africa. So we will want to engage to make sure that we're able to ensure that those we graduate are able to get gainful employment, not only locally, but internationally. Thank you, Your Excellency.
Thank you, Your Excellency. That just looks at some of the gains, and also I hope that our media, you recorded, you know, we are here for reforms that have been delivered. You recorded that Kenya is the 3rd in the world as far as health workforce data is concerned. I mean, the 3rd in the region and the 6th in the world. I'll move very quickly to service delivery. And here I will be asking from the private sector, Dr. Gakombe is here. 46% of the facilities now are private sector. The government has established the enabling frameworks for financing. How do we strengthen performance of service delivery at the private hospital level?
Thank you, PS Oluga, and allow me also to ride on existing protocols. It's true that the private sector is a key provider of care in the country. And because we must achieve access, achieve quality, and be efficient, one of the key things to achieve that, or one of the most enabling features or developments, is digitization. Because digitization allows all of us to keep track of what is happening across the entire country. And it allows us to tie all the facilities together, track referrals, and track outcomes, so that we can be outcome-based rather than purely focusing on the infrastructure available. And I want to take us back to a point when we had COVID. During COVID, the Ministry of Health scrambled to find ICU and critical care facilities. Today, that's not a problem anymore because SHA and the Medical Council and the ministry have live data on where that infrastructure is, whether it's occupied, and what is happening to the patients who are admitted in those facilities. Once we link up with the registration service so that we can record deaths and births on a live basis, we'll even go a step further so that outcomes can easily be tracked. So there's a lot that has happened, but one of the most critical is digitization, and the second one is the financing reforms. It's true we had NHIF, it had its challenges, we have SHA, and we've worked very hard to address some of the teething challenges SHA has. But for we in the private sector, payment comes from the patient. And many of them don't have money to pay. So having SHA pay their bills, having private insurance pay their bills, having employers pay their bills, enables more private sector service providers to thrive and grow. And for some of our patients, like dialysis, the only insurer and the only payer for the whole country is SHA. I do not know many places where there is anyone else paying for dialysis other than SHA, and the amount that is being paid is usually what we charge, because many of us are not charging anything beyond the SHA price. So we are keeping people who have end-stage renal failure alive through A, collecting money and channeling through SHA, and B, allowing private providers and paneling them as providers of service so that Kenyans have a lot more access.
Just in 1 minute, a very important thing. So His Excellency, the Deputy President, has just emphasized what the President mentioned about primary healthcare fund. Counties are here. They have made a lot of investment at that level, level 2, level 3, PHC, 27 billion, 23 billion paid. How do we shift the mindset of the private sector to invest in specialized services? 70% of PHC covered by government. we still do very less transplants. We still do very less cardiac surgeries. How do we shift the mindset of private sector that it is no longer very needed to just open up a clinic, pay very high rent, and Homa that the government has already invested at the village level? Just in 1 minute.
Our biggest job is to fill whatever gaps are left after the counties and the national government have provided service. So what you're anticipating is already happening. Many of our facilities, including the one I lead, are moving into more specialized care, renal, cancer, heart transplantation. And one of the key areas we are investing in, if you recall, that we've had a lot of traffic going out of country for treatment. And it's now policy that Kenyans should be treated here, close to home, near their relatives. That's a policy. And there is the money to finance it. So we are investing a lot more in upgrading care. I myself have brought the first robot for knee surgery in East and Central Africa, and we've already operated on 13 patients who would ordinarily have gone out of the country. And there are a couple more robots that have come in. So as KU does CyberKnife, Aga Khan is doing something else that is also quite specialized. We are doing something else which is quite specialized. And we'll be in Ethiopia on Thursday to tell them what it is that we can provide to them. So
Thank you.
We are regional.
Thank you so much. This is very important. And I'll bring in KNH. Yesterday you spoke in the town hall, you mentioned the establishment of the theater. So today, just tell us the outcome, the quality, and perhaps you bring in the technology, because KNH, you mentioned that is digitized for the first time, of course, with the support of DHA. So just tell us, how has that improved two things? One, experiences of patients, and number two, outcomes.
Thank you very much, Dr. Oluga. Let me recognize the presence of His Excellency, the Deputy President. Kenyatta National Hospital is the second largest hospital in Africa. In fact, we still remember and say that it is the largest hospital south of the Sahara and north of the Limpopo River. And it has existed for 125 years. It has provided services for 125 years, to this nation and also to the globe. When it comes to issues of specialized services, Kenyatta National Hospital with the University of Nairobi have not less than 500 specialists, in almost every disease burden, 500. And we actually focus on specialized treatment. We are actually the apex of the referral system of our nation, and we are also the apex of research in medical spaces. So what we are saying is that we have several reforms that have taken place in the last 4 years. And one of them is digitization, automation, and embracing technology. And we are automating and digitizing, the patient journey at Kenyatta National Hospital. From registration, triage, the imaging, to admission, theaters, pharmacy, up to discharge. And this has huge, clinical outcomes. And in fact, has a great patient experience in the sense that patients will be seen, on time. There will be no operational delays. There will be less, delays in payments, for example, in terms of SHA registration, in terms of SHA reimbursements, in terms of SHA claims. And therefore, that is one great thing that has taken place, at KNH. We are not yet there, but we believe that in the next 1 or 2 months, we will actually conclude not only on the clinical digitization, but also in the back office digitization, where we actually bring on board an ERP system to manage the procurement, to manage finance, and also manage HR. So I can also say that the last several years, we have managed to acquire, specialized, and modern equipment through the National Equipment Service Program. What in particular, when it comes to cancer, we now have 2 Linac machines. It has never happened at KNH for the last, I think, the 125 years. We are also going to get another LINAC machine probably by end of September. We'll have 3 LINAC machines, high-level machines. These machines will definitely, create, great clinical outcomes for our patients. All patients who will come to Kenyatta National Hospital suffering from cancer, requiring cancer treatment, will indeed, benefit from this. And these clinical outcomes, will definitely demonstrate that our health system is working. We are also, in the sense of clinical outcomes, we have also acquired, modern ultrasound machines. We used to have 2. Today we are having 6 through the same national equipment service program. This will also improve on the clinical outcomes when it comes to imaging. It will give us images, very fast images. The reports will be done very fast, and diagnosis will actually be done, additions made very, very fast. As I conclude, when it comes to issues of emergencies, I want to say that, through the ESCCF, Kenyatta National Hospital receives almost all the patients who go through difficulties in Nairobi and in this country. All disasters are managed at Kenyatta National Hospital. All motor vehicle accidents, in particular, probably also managed at Kenyatta National Hospital. All fires that take place in our country, in most instances, they are managed at Kenyatta National Hospital. With the ECCIF, those patients now can access, free medication the first 24 hours, and from there we move them to SHIF. And this actually gives us, great outcomes in terms of management of our patients. As I conclude, we are the only national hospital or public referral hospital which has got golf carts. Our patients who cannot walk, our patients who are old and elderly, our patients who are, pregnant mothers, when they land at our Kenyatta National Hospital parking space, when they land there is a golf cart waiting for them. We carry them to navigate the whole hospital. From the bus stage, they are taken to the cancer center in those golf carts. They are moved from the cancer center to the diabetic spaces. They are also taken to the bus stage, back for them to travel back to their homes. There is no any other hospital globally, I think, in a public sector.
Thank you so much. A round of applause for Dr. Lesiampe. We now have golf carts. I think he must be responding to experiences of patients so that we make it easier. I will bring in the National Assembly. Your Excellency, Deputy President, as you are already very well aware, the government has pushed for 4 pieces of legislation. The only piece of legislation that relates to service delivery, quality of care bill, quality of care and patient safety bill is still in the National Assembly. We've done Primary Healthcare Act, we've done the Digital Health Act, we've done the Facility Improvement Financing Act, and of course we've done the Social Health Insurance Act. Now, at the level of interaction of all this equipment, of the medicine, of the healthcare worker bringing his knowledge and expertise to ensure that the patient goes home with their problem solved, there's something we call the Quality of Care and Patient Safety Bill. And this is the last piece of legislation. And I wanted, as we discuss service delivery, that Parliament could comment on their role and how they see this panning out. Thank you, Chair, and welcome for this plenary.
Thank you very much, acknowledging His Excellency, the Deputy President. Legislation is key in all these things that you have said. Eventually, if they have to be enforced, there's need for legislation. And as you have indicated, the 4 acts, particularly Primary Healthcare Act and the FIF Act, has had tremendous effect, and then shift on top of it. So now we have the Quality of Care Bill and Quality of Care and Patient Safety. Basically, what this bill is attempting to do, or is planning to do, and which is supported, is actually to split the regulation of personnel, the professionals, from the regulation facilities. I think that is the summary of it. And this is important because there's a lot of overlay that come together. And when you get that, then you can now say we regulate the personnel, the professional like this, and the facilities are regulated. And there are a lot of issues that will come with regulation facilities, how they are accredited, how they are empaneled, and so on. So that is important. This has actually passed through the National Assembly and is actually going to the Senate, and we are looking forward to it. What I know and the challenge that we'll face, and I think the minister is up to it, it is going to affect very many other acts, laws that are in place. And when we are looking at it, we looked at this, and I know very many professionals will come up, and the issues will have to be sorted out, and we must put a transition process which is very well worked out so that it doesn't bring clashes. But there's also one else, probably. We already have an authority act. Again, that is important if you are going to wow. We have the drug authority bill that is also in Parliament. It has passed through the National Assembly, is in the Senate, because that is going to be key if you are going to go in drug manufacturing. There is a need of a level that we need to, and that will be important. Again, that will be splitting the regulations of HPTs, health products and technologies, from the regulation of professionals. And I think all is important. So many things that we are looking at, Parliament is key. Another element we probably didn't ask is the area of appropriation. And I must really praise the government and the ministry, because where we have actually appropriated, we can see the results. And so with the National Assembly, in terms of legislation and also in terms of appropriation, it's extremely important. That's all I can say for now.
Thank you so much. You know, Honorable Chair is a very senior health professional in this country. Please, let's clap for him for those very good comments. We want to move to the last session of health products and technology. We've heard a lot about KEMSA and the last mile delivery, and your clients are here today. Please don't dwell on the debt. Just dwell on how you can get the facilities to get medicine. And this thing, Waziri mentioned it in his remarks. How do we cure the disease of Hakuna Dawa Hospitali? And because the governors are here, and as you make very few comments, I will also be calling the chair of the Committee of Health just to wrap up on that bit about how do we ensure that last mile delivery before I bring back the CS to proceed with the program. So, Honorable Dr. Edjesa Wako, the floor is yours.
Thank you, PS. I recognize the presence of His Excellency, the Deputy President, and the protocols as established. Thank you. I think this is a very important discussion that we should have. Those of us who have done public health practice, there is the adage that goes, no commodities, no program. So whatever we do, if we don't have the final products, then we are not talking about health. So we take cognizance of that in KEMSA, and we said as part of universal health coverage, what can we do differently to cure this Hakuna Dawa syndrome in the head? So we sat like 3 years ago, we sat and discussed and said, what do we need to hit? What are the high impact interventions? In life and in programs, you can do so many things, but what are the high impact interventions that we can hit to score, to move from 40s to 90s? Now, then we sat and said, KEMSA is not a traditional supplier that pushes boxes to facilities. Let us engage the counties, our customers, the facilities, and ask them what really matters to them. What do they require to give optimal services, and what do they need? What are the needs? Because we found a KEMSA struggling with buying a lot of things, quite a lot of things. Yes, it is good to buy so many things, I can be specific. We were chasing 3,800 SKUs. SKUs are stock keeping units, call them products, including technologies. Now we said, does the country require all this? To us, not. So we don't make decisions for our clients. Let us look at the trends. What have they been ordering over time? Then we realized they were ordering barely 500 items over the last 5 years. Yes, this is information available to us and in our systems. Let us corroborate this information with our clients. So we invited our clients. We had a national dialogue through the county pharmacist. I'm happy the governor has released all of them to come and discuss with us what are their needs. They actually confirmed our fears that KEMSA has been struggling with the limited resources to buy all these molecules, and we settled on those, and we said, let us buy those products. Then there's the traditional policy that a supply chain must hold 6 months of stock in its warehouse. Do we have money to keep 6 months of stock? We said, let us do what we call shrink and grow. Let us be realistic. Let us keep stocks for 3 months and churn around, because those are the small resources we have. So we decided to shrink and said, keep amoxil for 3 months, not for 6 months, because 6 months would be too expensive. So by smartly looking at the products and the time we need to keep our stocks, and we went into bulk buying. So, it's different for you to buy things, and it's different for KEMSA to buy things in bulk. We get the economies of scale. We address the affordability issues. Then, because of time, I'll rush through. We looked at framework contracts. We found a KEMSA that was struggling to give contracts every year. So before you realize, the contract is finished and you have no supplies. So we went into framework contracts, minimum of 2 years, so that a supplier has a predictable deliveries that they make. So, and then digitization, finally. Digitization, very, very key. We have what we call an ILMS, which of course our Excellency, the Deputy President and the President and my Minister have always said we move to DHA, fine. But at the moment we have the ILMIS, which has, let me just talk about one module called CWAS. CWAS is very good for us. Commodity Early Warning and Alert System. So at all levels, it will tell us where do we have stockouts or overstocks. Is KEMSA overkeeping? Our facilities also overkeeping? What are the optimal? So it gives us alert in terms of colors to tell us, now there is a lot of stock at KEMSA. Can you offload this before you initiate procurement? I can see I'm being pushed for time. I recognize that, and I thank you very much. I'm ready for any questions.
Thank you. Thank you so much. Round of applause to all the panelists. Please, let's have our seats as we just have Governor Mudomi Njuki wrap up in just 2 minutes, please. And then you call CS Aden Duale to proceed with the program. Rest of panelists, we want to thank you so much. Let's have our seats.
Your Excellency, I just thought will not do justice to one aspect of human resource that we haven't spoken about, and that is coordination between the national government, that is MOH, and the county governments on the issue of human resource. And that coordination is what would really deliver the results that we desire and avoid the industrial arrest that we've had at the moment. Initially, we used to have situations where we had a standoff between the MOH and the counties on the issue of industrial unrest. But nowadays, Your Excellency, we sit and
resource that we cannot able to address because we are paying people who are in Kenyatta National Hospital, Moi Teaching and Referral Hospital, KU, who are actually working there on training, and they have left gaps in our counties that we need to fill, but we can't fill because we don't have those resources. Our request or ask is that the national government or the ministry takes up both the training and the payment of salaries during that time, so that we can be left also to fill that gap by having short gap, maybe contracts for those who would wish to cover for 1 or 2 years, so that we do not have that gap. That is critical for us, so that we not continue having gaps throughout, even as we continue training. Thank you very much. Honorable Dwale, the CS.
You know, Your Excellency, your governor, he did not say, I inducted him to parliament, I allocated him a committee of his choice, and later he became the chairman. So him and Governor Abdul Samad, Governor Mandago, now Senator, Dr. Pukose, and many others, when history is written, they must have a small paragraph or a page about me. Your Excellency, just to, because I don't want to speak, but just to react to what Governor Mudomi said on postgraduate students who leave county facilities and go to study. On one side, I'll agree with him, and we are in agreement that the speciality will not be decided by the doctor we are sending and paying for. It will be decided on what are the gaps missing in that county. Because we can have 3 people living in the county going to do the same course when that county requires an oncologist, when that county requires another specialty. So we are working with the DG, and we want to make sure that we put that in order. But paying them is a responsibility of county governments. But again, county government, Your Excellency, when they pay, the problem the county government face is this. Some of the students take longer period, 9 years. The county governments have to replace that person. Because by a HR person leaving means they must replace. So it's like they have to look for extra resources. But I think that is a matter we can discuss at IBEC between the 2 levels of government. This is above my paycheck. The person who deals with IBEC resources and how to balance the resources which are shared between the 2 levels is not the Minister for Health, is the Deputy President and the Chair of the Council with all of us. But I think it's a matter that we need to relook at. But I agree, and we have said counties will say we need a pediatrician, we need an oncologist. So it should be, the need must come from that particular county. Different counties have different needs. Your Excellency, I don't want to go more than this. Me and you, we talk a lot in many years in Parliament with Abdul Samad and Mudomi. So I want you to come and wrap up. And I know your wrap up, those of us who have pens and papers, please take note, because the summary of the Deputy President is always based on data and factual, so that we can tell the people of Kenya. People are very happy online. I was seeing that they're saying this summit is very informative. So I think the Deputy will summarize for us. Your Excellency, it's my honor to invite you.
Asante sana, ni fire si fire. Let's keep it short. We've been here since yesterday, and I want to thank all of us. Of course, we are again having another session, which will be presided over by His Excellency the President, so that we can have takeaways. But allow me, in terms of delivery of government, both levels of government, to say we have made progress. In 2022, President William Ruto and the team that were campaigning for his election as president promised we will reform the healthcare system, something that we had struggled for many years without success because of the pushback by political interest, business interest, fraud and cartels that were benefiting from the misfortune of the people of Kenya by way of illness, profiteers, and all manner of characters. And the pushback has been there. Those of you conversant with Kenya's political discourse know President Mwai Kibaki, through Minister Charity Ngilu, tried this thing. There was pushback and he gave up. We also know, those of us who have been following Kenyan political issues, President Uhuru Kenyatta, through, I think Kibaki was through Professor Anyang' Nyong'o, Uhuru Kenyatta through Charity Ngilu, or is it Charity Kariuki? So Sisiri Kariuki, I think. Tried under the Big Four agenda. UEC was there. Pushback. He gave up. So President Ruto said, we will reform this thing. Luckily, he expected the pushback would be there. But he promised the country that he will weather the storm, risk his popularity in the short term until we get this thing right, and his popularity will be back. Imefanyika, haijafanyika. The noises that you used to hear that SHA is not working, whoever is criticizing SHA now is whispering. But when we started, especially the initial months of rollout, it was terrible. You would think that Kenya has come to a standstill. How Kenya is a mess. By that time, we had not even activated some of the funds, like the ECCIF, the Emergency Chronic and Critical Illness Fund, was not operational. So there was chaos all over the place. But today, it is true there are people still who are criticizing, which is also okay because you just make us perfect things. Sometimes the only thing we ask is that you do it, those who are criticizing us should do it factually, not through generalities and through falsehoods. So this has been a heavy lifting of 4 years of hard work by the national government and county governments and the people of Kenya. We've made progress. And what we have said in the last 2 days, and we'll be concluding this afternoon, is there is still work to be done. We need to fine-tune things. But at least now, the framework and the system is in place. The program is now on its track. We just need to fine-tune a few things. What are the 5 things that we must now work on going forward? Number 1, the people. And I'm summarizing what we have said from yesterday morning. The people. The universal health coverage, Taifa Care, is about the health of the people of Kenya. So the bottom line is about the people. Better quality healthcare for the people of Kenya. How far have we come? From 8 million to 32.3 million today. Isn't that a great progress in terms of universality? Because we have had a healthcare program before. NHIF had a public medical insurance cover, but 8 million, 32.3 million, a huge leap, and still counting. I have been advised by those who are better than me in mathematics that we are now around 60% coverage. 32.3 million is about 60% coverage. If you add those Kenyans who are on a private medical insurance, we are approaching 60-something% coverage. That is not a small measure. Compare it with other countries for you to understand. Minister Duale and the team there, President Ruto, and all of us, when we visit other countries or leaders of other countries visit us, they're asking us, how did you get to pool by now 32 million Kenyans on UHC? And counting, because we must up the game. I am advised that 75% plus is what becomes universal health coverage. We are almost there. Some counties have achieved universality. I salute Governor Abdulswamad of Mombasa and 3 other colleagues of his who are now in the 70 plus, with Mombasa leading. It appeared impossible 4 years ago. Today, universality of healthcare is a reality because of numbers, the number of Kenyans who have some form of medical cover, which may not be perfect, which is being perfected, which is being fine-tuned, but at least when they fall sick, they do not have to rely on quacks, magicians, sorcerers, and manipulative religious leaders, some of whom take advantage of sick people. They have a medical cover. That is what universality looks like. We are smelling it. It's around the corner. Some counties have achieved it, others are on the way. So the target, therefore, we are hoping by the end of this year, we are talking about 40 million. By the time we go to the election, we should be talking about 45, 46. If you add the ones with private medical insurance, almost every person in this country will be having a medical insurance. Tuendelee tusiendelee. It is about the people. We must carry the people along. It was not possible under NHIF for someone without a job, without some ascertainable income source to be covered. Now, everybody, from the indigent to the poorest, to whoever does not have anything, is eligible. That is transformation. And we applaud all of us for the progress this far. There is still work to be done. We've treated, you've heard the numbers, I think 20 million patients who have been treated in the primary health facilities. We've had the money we have used. We've received 27 billion so far under the primary health care. We have disbursed 24 billion, and 67%, almost 70% of that money has gone to county government facilities under the primary health care fund. Today, the sustainability and the financing of private health, of public health facilities is now becoming a reality. We still have work to do to improve on that. The people, the numbers around the people of Kenya who are covered, what they are benefiting from, and the targets for the future is one of the things we must work towards, because these numbers are not just statistics, they are about human beings. And universality is about the numbers. Number two is the health workers. In 2022, we didn't have frontline health workers. Some counties had community health volunteers, others did not have. So President Ruto and the Council of Governors met and agreed to have uniformity. Today, we have an army of 107,000 community health promoters, paid a stipend, half by county governments, half by national governments, leading the war against disease in the villages and the households of Kenya. 107,000. And yesterday the president launched the next phase of replenishing their kits so that they can have better kits for testing and diagnosis and doing household health advice with better kits. We are also, the president has also talked about the possibility of us reviewing their stipend to make sure that we have a motivated frontline army. But we also have made progress. You saw in the statistics from the president, from myself, from the minister, from the Council of Governors, that we have also, the national government has been able to post or to place 24,000 interns, medical interns, health workers, CHPs, medical interns, 262 registrars who have been facilitated to further their education and to specialize. But there is a commitment now which is being realized at the moment of hiring 5,000 nurses and midwives to protect especially our mothers, to make sure that we achieve that aspect of our health system. So about personnel. But we have also been able now to regularize the employment of 7,800 UHC staff. Again, work in progress. There are small things we need to fine tune, and we've just had a discussion with the chair COG. We have agreed what we need to do on that UHC to make it a seamless part of our healthcare worker system as possible. So the personnel, it's about the people, it's about the health workers. That's what we've been talking about the last 2 days. Number three is about the equipment. If you enroll people and give them a medical cover, and they have a medical health worker either coming at home as a CHP or in the hospital as a nurse or a doctor, that's not enough. And by the way, Governor Abdullahi of Wajir, the chair of the council, was telling me there were 800 doctors, now we are talking about 5,000 doctors. I didn't know. He was also telling me when he started in Wajir, the first time as governor, he had only one doctor at the main hospital in Wajir. Today, he has 70 doctors in Wajir, including 20 specialists within Wajir County. Is that correct, Mr. Chairman? Yeah. So that is what personnel issues, that is the journey we've covered, and it's still work in progress. But number three, I said it's about equipment. You have the people, you have the health worker, but they need an interface called equipment. Therefore, through the National Equipment Support Program, we have placed so far equipment worth 9.8 billion shillings in 239 health facilities in 44 counties of the Republic of Kenya. And that work is ongoing. Equipment you will not have imagined. CT scans, the MRIs, the lab equipment and so forth. There is a lot of equipment placement ongoing through a fee-for-service arrangement, whereby it is up to the person who owns the equipment to place the equipment, take care of the equipment, look for the consumables, make sure the equipment is working, maintain it, and the work of the patient is to come and get diagnosis. And once that diagnosis is done, the bill is sent to SHA, and SHA settles the bill. So it is up to the owners of the equipment to make sure the equipment is working, because if it's not working, they will not be paid. They are paid for every service that they deliver. So again, this equipment thing is work in progress. We have looking forward, we need to work on level 2 and 3 a little more, so because that's where much of the early diagnosis is done. And I think that progress is something we need to be proud of. So you have the people, you have the health workers, you have the equipment. Number 4 is, and maybe this should have come earlier, the legal and institutional framework to deliver. Maybe it should have come earlier, after the people. The legal and institutional framework. That is why, and here we salute our houses of parliament, and we salute all of us for our various roles that we played to make sure that we have anchored this program under sound legal and institutional framework. Today, the laws are in place. The Primary Health Care Act, the Social Health Insurance Act, the Digital Health Act, and the FIFA, which is Facility Improvement Financing Act. You have the 4 laws. But we also have the funds, the 4 funds. Under the Facility Improvement Finance Act, you have the Facility Improvement Finance, which is retained at the facility to improve the quality, the service, the level of service. But we have the other 3 funds, the Primary Health Care Fund, the Social Health Insurance Fund, and the Emergency Chronic and Critical Illness Fund. Work in progress. But we also have the institutions. We have SHA, and we have the Digital Health Agency. That is the framework. And we are being told now, in terms of the future, of 2 legislations that are work in progress. One, and it was raised by the panelists, the high-level panelists who are here just now. One is the Quality of Care and Patient Safety Act, to make sure that this level of service delivery is standardized and of the highest quality. And then there's one which was mentioned by my senior here, Dr. Nyikal, the one on drug something, Kenya Drugs Authority Bill. Those 2, so that if we go into manufacturing, as we should, as we have said we should, then that is the law that will help us fine-tune that area. That is the work around legal and institutional framework. 90% done, a little bit remaining to perfect it. Then finally, number 5, it is the commodity logistics. We've heard what KEMSA is doing to improve drug supply. We've heard how we've moved from 40% to 90% in terms of availability of the drugs which have been requisitioned. But there is need for more work around KEMSA. And one of the suggestions that came from His Excellency the President, and I have repeated it here, is that the system which KEMSA is calling integrated something, medical, what is that MLIS something? Integrated, give him the mic. Integrated logistics.
Integrated Logistics Management Information System.
That system is good, but it must be interoperable with the data, the medical data under DHA. Because it's about supplying commodities for this system. So you cannot have all the other data separately in this data. The two systems must speak to each other. And that should happen sooner than later. And in the next IBEC, which is on Monday, or maybe the next one, some of the things we agree here, we should pick them up so that we start running with them. So about commodity supply, commodity logistics, we've made some progress. KEMSA was in disarray in 2022. We gave them 1.5 billion. We got them a line of credit of 10 billion, and we are happy with the good work that is ongoing there. But there is more work to be done around health commodities availability. But we have also 922, the National Ambulance Dispatch Center, an emergency number to provide ambulance services to patients who have emergencies, who have medical emergencies. You get the ambulance. First of all, the number is toll-free. That 922 is toll-free. Secondly, it should link you to the nearest available ambulance. And we must make sure the ambulance is available in good time to save lives. But also it is attached, that package is attached to emergency treatment. The first 24 hours of emergency treatment should not be pegged on anything, whether someone has a cover under SHA or not. They must be stabilized as now they get registered into SHA and other things follow. So again, around commodity and medical logistics, the ambulances, the commodity availability of drugs and so forth is work in progress. Those are the 5 things: the people, the legal and institutional framework, the workers, the personnel, the equipment, medical equipment, and then the health commodities and logistics. With one enabler, those 5 things, we are fine-tuning them as we fine-tune the main enabler of those 5 pillars of our UHC is going to be digitization. The work that DHA is doing, technology, digitization of how we manage all these pillars is key and is work in progress. And this digitization will help us resolve the biggest threat, the biggest single threat to this program and to all medical insurance programs around the world: fraud. It is digitization. And what DHA is doing, that will help us fight fraud, because fraud interferes with the medical actuarials. Because the insurance is around actuarial estimates. How many people are paying how much? How many people get sick? What are the benefits like? What is being paid out? Fraud interferes with the health of the actuarials. So DHA has the solution. The sustainability factor is going to be around digitization technology, and making sure that we fight fraud. Thank you very much. God bless you for your time, and I think we are in a good place. But there is a session coming at 2:30, around there, the minister will announce what time, where His Excellency the President want to come and listen to what all the participants consider to be the takeaway. What is the take home? What is the experience? What is the agenda around the issues we are raising? Then he will give now the final strategic address, which will now send us back to our workstations. If I. Minister Duale.
Thank you so much. Let's appreciate Prof. I'll request Your Excellency kindly to remain on stage. The rest of us kindly let's have a seat. Your Excellency, allow me only for 3 photos. The first photo, the ministry. I'll invite the CS, the 2 PSs, the Director General, and kindly for the first photo. Then the second photo, governors to be ready. So we'll have the first photo with the ministry as the choirs are taking their position. Let us balance. Let's balance like that. Thank you so much. The Kenya Health Summit 2026 reforms delivered health as a right. Thank you so much, governors. Governors, kindly join. Governors, Their Excellencies, governors led by the chair of the COG, the deputy chair, chair health. Karibuni sana. Thank you so much. A bit faster because His Excellency the Deputy would wish to receive the principal. Let's come forward a bit. Hapo tu, Madam PS. Hapo tu, tusiruke. That's better. That's better. Yeah, that's enough, Madam PS. Thank you so much. The last photo, all of us to leave and allow the Deputy President with the panelist. The rest of us kindly resume our seats. The Deputy President, Waziri na watu wake, Waziri na watu wako, the ministry. Waziri usiondoke tafadhali. Waziri, it is your role. And the panelist. The panelist. Let's do that. That's okay. The panelist. And that is our last photo so that we can give room to His Excellency to proceed to the other side. Thank you so much. All of us to leave and allow the Deputy President to remain on stage. The rest of us to leave the stage as I invite all of us to be upstanding. Niombe sote tusimame wima, walio na kofia ambazo si rasmi kuweza kuzitoa kwa ajili ya wimbo wa taifa. Thank you so much, Your Excellency. We've come to the closure of our function. Asanteni sana. We invite, as we leave His Excellency to leave, the rest of the VIPs will have a debrief at the opposite tent. All the other VIPs, governors, PSs will have a debrief at the opposite tent. Ningependa kusema asanteni sana wananchi. Mumekuwa watulivu tangu saa 2 asubuhi hadi sasa. Jipigieni makofi jameni. Nyinyi ni watu wa heshima, nyinyi ni watu watulivu. Ninawaheshimu sana. Nimshukuru mwenzangu MC Alex kutoka ofisi ya naibu wa rais kwa usaidizi wa karibu. Tumefanya kazi kwa pamoja, ni mwanafunzi wangu. Kwa hivyo mwalimu anapoona mwanafunzi anakolea, anafurahi sana.
duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Palipo njaa na mashaka nilete faraja,
Wakenya wote waishi kwa umoja, kwa kweli.
Palipo vita na majeraha nilete amani,
Wakenya wote waishi kwa amani.
Palipo mipaka ya kisiasa nilete umoja,
Wakenya wote waishi kwa umoja, kwa kweli.
Palipo vita vya ukabila nilete amani,
Wakenya wote waishi kwa amani.
Baba Mungu, kutembea sehemu zote za Kenya, nihubiri amani na msamaha, tutumie madaraka yetu. Oh, Baba Mungu, sehemu zote za Kenya, tukomeshe vitendo vya ukabila, tutumie madaraka yetu. Yelele, yelele.
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze